conducted, oh, that helps, thank you. An interesting survey conducted by the U.S. Department of Agriculture showed that 62% of the commercial operations are within 1 mile of backyard chickens. So not only do we have a lot of backyard chickens, but they're in close proximity to our poultry farms. We have game birds, game fowl, hobby fowl, just significant variety of different avian species there. And there's a lot of movement. Unlike commercial birds, there's a lot of movement of these non-commercial birds, going to markets, going to exhibitions, and there's smuggling. There has been known to have smuggling of live poultry and poultry products between our borders, particularly with Mexico. And in fact, it's a smuggled rooster was incriminated in causing the exotic Newcastle disease outbreak in California, which took over 9 months to contain and well over $100 million of the cost to USDA. This virus can also be easily imported on vehicles, footwear, clothing. It really transports very easily and very well, which also raises our risk. And we really are learning more about the role of waterfowl, but are not quite sure about its role in causing the spread of this virus to Georgia. And we have significant numbers of waterfowl and continue to learn more. But the good news is, yes, Georgia does have a plan. We don't think the sky is falling, like Chicken Little says here. We've been working on it, as the commissioner said, for months and months, probably a year and a half now, with due diligence. And in fact, we've dropped many of the routine activities of our programs. We've put them aside and set them as a lower priority in order to take the necessary resources that we need to develop this plan. I want to mention the Georgia Committee on Agriculture and Food Defense, because our Office of Homeland Security is also an integral part of this plan. You might not know about this committee. It was formed over 3 years ago, and this was really the first time that agriculture was included in our state's Homeland Security initiatives. It's under the direction of the Homeland Security Task Force and reports to the governor. And I'm pleased to report that just this past April that a seat was assigned to the Homeland Security Task Force. So now agriculture and food defense is represented in our Homeland Security Task Force in the state. Our committee is multidisciplinary. You see many Georgia departments are represented there. Georgia Emergency Management, Georgia DOD, Public Health, which has been a tremendous partner for us, because this virus, as I mentioned, does occasionally spill over and affect the health of humans. Georgia Department of Natural Resources with the wild bird surveillance is a very significant partnership. Department of Transportation, FBI, wonder if this virus were intentionally introduced for agro-terrorism into our state. So it's important that we network with the FBI. USDA Animal and Plant Health Inspection Service, who Dr. Arza represents, the UGA College of Veterinary Medicine and College of Agriculture and Environmental Sciences, Georgia Tech Research Institute, Georgia Farm Bureau, Georgia Agribusiness Council, Georgia Food Industry, Georgia Poultry Federation, and this is not an inclusive list. So you see we've gone to great lengths to bring all the partnerships together, both from the academic sector and the private sector, working with government. So we make sure that we have a collaboration group on this plan. So even though the Department of Agriculture has taken the lead, it truly has had input from all of these stakeholders. But Georgia Department of Agriculture is the primary agency for our Emergency Support Function 11, which is in our Georgia Emergency Operation Plan. And we're responsible and have the authority to control and eradicate animal and plant diseases and pests. So not only, of course, with animals, but also on the plant side. We also have the authority to provide the safety and availability of food at the processor, wholesale, and retail level. So we really are in charge of the continuum from the farm to fork or gate to plate, that continuum of food safety and defense. The goals of our Georgia response plan for avian influenza is to rapidly detect it, control, and eradicate an outbreak in all types of poultry. And that sounds pretty easy to accomplish, but difficult to do. The detection part is critically important for us because this virus is probably the most contagious virus among animals. And it's much like a brush fire. If we do not get ahead of it rapidly from the get-go, then we may lose the battle. So it's very, very important to rapidly detect it and to rapidly put all resources we can to control for its spread. Our plan serves as a guide and a framework because the virus continues to mutate, it continues to have new presentations, and so we need to have that flexibility to respond as we need. And it's consistent with the National Incident Management System, the National Response Plan, the USDA guidance, the Georgia Emergency Operation Plan, the Georgia Reportable Animal Disease System, all these other alphabet soup acronyms, guidance that we're required to be consistent with both at the federal and state level. But it starts with a very robust surveillance system in commercial poultry, backyard birds, and wildlife. In commercial poultry, I think you, Chairman Cox, mentioned about the Georgia Poultry Laboratory. And the Georgia Poultry Lab is a component of the Georgia Department of Agriculture. In fact, the Georgia legislature funds their budget through the Department of Agriculture. So they really are one of our agencies. And you can see there from the chart during the last 12 months, they are testing some 23 to 25,000 tests per month on commercial poultry. So we have a very robust system. Thanks to the legislature, they now have some of the most modernized equipment available globally to do these tests in rapid fashion. We're also looking at non-commercial poultry. Our Department of Agriculture employees are out at poultry sales inspecting over 150,000 birds that go through these sales, and we really think this may be indeed our high-risk population, as I explained earlier. We tested nearly 4,000 birds during the fiscal year of '06, and we're seeing an increase in these sales. We had an increase of 50 sales from FY05, and many of these are on Friday and Saturday night, and you see the conditions there which our employees are working in order to draw blood on these birds and send it to the laboratory for avian influenza testing. Wildlife surveillance is also being conducted in Georgia. It's being directed by USDA Wildlife Services and the Georgia Department of Natural Resources. They're concentrating on these species of birds which are known to be associated with avian influenza viruses. On the left, you see shorebirds, gulls, terns, and other shorebirds. On the right, waterfowl of ducks, geese, and swans. And so they're focusing on mortality, those that have died, to collect samples, and also conducting environmental sampling. It is serving as an early warning system for the presence of the virus. If we get virus in many of these species, we know we have it in the state of Georgia and it's circulating in these species. We're trying to make sure people are aware and they know who to call to report suspicious diseases in live birds. Georgia law requires that anybody that has a suspicion of avian influenza, that they report it to our office, report it to Dr. Arz's office, or we also encourage, if they can't reach us, to call the Georgia Emergency Management Agency, the Communications Center, which is always open, or their local veterinarian because they know who to contact. But if we detect this virus, this detection will trigger an entire cascade of events. We will establish a unified area command with Dr. Arza and I serving as unified commanders, and we will set the overall mission and policy of how to respond to the incident. We'll also activate a Georgia State Agriculture Response Team, which are newly being formed. They will oversee the actual incident in the field level. And a part of this is we will actually be asking the governor to declare a state of emergency. We have worked with the governor's office with the help of GEMA and actually drafted an emergency declaration so we don't have to wait, because as I mentioned, it's imperative that we quickly respond, and we can't be running policy through attorneys and others to get clearance. So the more work we can do ahead of time, the more rapidly we can be prepared to respond. But it will take this governor declaration to release state assets, which are going to be so critically important for us to bring together. We'll also request that USDA, the Secretary of Agriculture, declare an extraordinary emergency. This will release emergency federal funds. Unlike other emergencies that you might be more familiar with, in this case, FEMA does not have the checkbook. It's USDA. It's the Secretary of Agriculture that has those contingency funds to pay for indemnity for birds that we might have to destroy, to pay for cleaning and disinfection, to pay for ancillary costs associated with that. So it's so important that we follow USDA guidelines to do that, and we give the information the Secretary needs in order to pay for that. Our plan has some special features that might not necessarily be in other animal disease plans. Special features include a worker protection plan. We've put significant efforts into making sure that we have the protections that our workers and farmers need to protect themselves against this virus. And we're fortunate that we've been working very closely with the Department of Defense, the National Guard, who serve as really our line forces with the most experience with hazmat and dealing with biological agents, and also with the Division of Public Health, who have helped take the lead in crafting our worker protection plan. And we hope to have our first training in worker protection in February, which will actually be offered by the Georgia Tech Research Institute. We have a significant communication plan. All the public information officials of various state agencies in the private sector have come together to work on this plan. Our press office at our department has been one of the lead in doing that, along with Buzz Weiss, I see sitting here with Georgia Emergency Management Agency. We've diligently put many hours in communications because, as I demonstrate a few minutes later, that message is going to be critically important to protect our industry and our citizens as well. And there's a role for the private sector. I believe you mentioned, Chairman, about going out to some poultry farms. The committee was able to do that and see the importance of the private sector being able to act very quickly, because, as you know, the private sector can act more quickly than government. And so even though we're ramping up to be very responsive, the private sector, there's many things they can do on their own, and how can government help the industry be better prepared? And this is probably an area that we could do better at, quite frankly. Crisis management, the role of the FBI, I mentioned the importance there. And what do we need to do if it's detected in a non-traditional animal species? This virus, as it continues to mutate, it continues to be found in very unusual species, and in fact it has been isolated from cats and it has been isolated from a domestic dog. Our state agricultural response teams, you see that circle in northeast Georgia. We have established our SART-1, our state agricultural response team there in GEMA Area 1, with the focus on H5N1 avian influenza. And we're partnering with Hall County Emergency Management Agency to serve as an incident command post, and our Chicopee Woods Agricultural Center there in Hall County as our staging area. So we've made significant strides because of federal dollars from Homeland Security that we have put into trying to make sure our teams are organized, planned, properly equipped, and trained in order to respond. This is just a map out of our HiPath AI plan to give you a little bit of an idea of the scope and the magnitude. In the center there represents one infected premise, and if one infected premise were detected, we would go out with a surveillance zone of 12.5 miles, which is out to this circle here. So 12.5 miles from the radius of this one infected premise, which in essence would be a 25-mile swath there, would be just a flurry of activity in that surveillance zone. The buffer zone would come out some 25 miles from that infected premise. So this buffer zone represents a swath of 50 miles. And that's from one infected premise. Do you think we'd be so lucky to have one infected farm? It's never been that way before. Usually there's an outbreak that involves several farms or clusters of farms. So you can see the resources it would take, that buzz of activity, so to speak, within that 50-mile radius. What would we be doing? We would be conducting surveillance and epidemiology. We would be looking at birds, trying to detect if there were ill birds, conducting postmortems, collecting samples, sending those in. Non-commercial poultry would also be affected, and in fact this may actually be the most demanding on our activities, is going door to door or house to house or premise to premise, trying to find out if there are non-commercial poultry or other affected species on that homestead. This is an actual picture from California from the exotic Newcastle disease outbreak, which affected mostly non-commercial poultry. And during that outbreak, there was, at the height of the outbreak, some 1,500 people on the ground at any one time, and there were some 7,000 people that were rotated through this incident command system in order to contain that virus in California. We're practicing also depopulation. We're very familiar with depopulating small numbers of birds, but what about millions of commercial poultry? How would we do that expediently? How would we do that to make sure we protect the environment? And last but not of the least important is how do we do that humanely for the welfare of the animals? Some of the new technologies we're looking at is actually fire foam. This has been researched mainly in Delaware and Maryland, and USDA has recently approved its use for certain types of emergencies, and avian influenza would certainly fall into that category. The way fire foam works is it actually takes oxygen out of the air, which distinguishes the fire. Well, in the case of euthanizing birds, taking that oxygen out of the air, and with those bubbles also they have found have been able to euthanize birds just as humanely as using carbon dioxide, which is more of the traditional method. Cleaning and disinfection, just a host of policies and procedures that will need to be in place to make sure we don't transport this virus on footwear or vehicles. And all of this is going to take a large response team in order to get all of this done. As I mentioned, some 7,000 people went through California. Our entire Department of Agriculture has a little over 700 employees. That's the Division of Animal Industry, which I'm in charge of, but also the Division of Consumer Protection, the Division of Marketing, our Administration Division. That includes secretary, clerical staff, everybody. We simply would not have enough people to really register a significant response if we solely relied on our department. So we really are going to have to reach out not only with USDA but the private sector, typical emergency responders, law enforcement. We're going to need state assets, and we're going to need them quickly and going to need them trained in order to respond. I wanted to mention just a couple of impacts from the economic and social perspective about this outbreak. If we have an avian influenza outbreak in the state of Georgia, we'll have significant interruption of our trade. As I mentioned earlier, the 25 million pounds of poultry meat, Georgians alone don't consume that. About 17% of our poultry is exported. We heavily rely upon exports to other countries to really feed the world. And so if we were to have an avian influenza incident in the state, all of those exports would cease. We could possibly see a drop in poultry consumption. In fact, that happened in Europe, both in Italy and other countries. It dropped some 30, 40, 50% in some areas. People were afraid to eat poultry. There'd be significant quarantines and movement, as I demonstrated on the map earlier. That would have significant economic impact on that farm gate value. How do farmers continue to be in business if they're under quarantine for 9 months? Who's going to make that mortgage payment on those chicken houses, which can be $250,000 a piece or more? There'd be severe disruption of our poultry production. Chicks wouldn't be replaced for months and months. So there could be potentially long-term economic impacts from this outbreak. some of the communication issues that we're focusing on. We're trying to get these key messages out, however, that it's not all doom and gloom, that U.S. poultry is safe for consumers to eat. And avian influenza is an animal disease, as I mentioned. It's not a human disease, and we have all these firewalls in place: the biosecurity, the surveillance, the inspection and processing, the reportable disease system that we have in place. In the United States, 99% of the poultry we consume comes from the United States. So in Georgia, with so much produce, most of the poultry we consume in Georgia is from Georgia. And so that's some of the messages we need to get out. Lastly, I wanted to mention some of the things that the Commission for a New Georgia discussed last year. We were fortunate enough to be involved in this agribusiness technical advisory group. And as a part of that, there was a food security subcommittee task force as part of this Commission for a New Georgia. And we were part of this initiative for a healthy Georgia. And these are 4 of the recommendations that came out of this commission. And the first was to support Agriculture and Food Defense Division in the Georgia Department of Agriculture. Yes, we have done a tremendous amount of planning. We think we are as prepared as any other state. But the resources we've used to do that, we've taken out a hide. As the Commissioner mentioned privately, I think, that our budget's been cut, where we have just a little over 700 people in our department. And so we have no dedicated resources to focus specifically on agriculture and food defense. And this is really needed in the Department of Agriculture, because some of our other programs are suffering because we've had to take so much of our time and resources to spend on ag and food defense. Many other state departments of agriculture across the nation have these specialized individuals. One individual I would like to see in my division is a poultry veterinarian. You know, with Georgia being the top poultry state, the Georgia Department of Agriculture does not have a veterinarian that has specific expertise in poultry diseases. That's one example of some of the resources we think that we need. Secondly, the Commission for New Georgia suggested that we implement educational programs that harden potential Georgia agribusiness targets. The private sector is such a large component of this. We really could use some funding to develop programs that educate producers, agribusinesses such as processors and others, where they might be vulnerable, how they might harden their targets. There's been no state resources invested into the private sector to help them do this. Thirdly, we thought it was a good idea to support an annual Ag and Food Defense Symposium that was hosted by the governor. This could be done very easily with the governor's Emergency Management Conference. To date, that's not been done, but we hope in the future that would be considered. And lastly, the one thing that has been accomplished is including the chair of the Georgia Committee on Ag and Food Defense as the official member of the State Homeland Security Task Force. This was actually one of the first tasks that General Nesbitt accomplished when he assumed the leadership role for the Office of Homeland Security. He recognized that Ag and Food Defense was not part of the state's Homeland Security initiatives, and it's very difficult for us to think about any other security if we don't have food to eat or potable water to drink. So we are very pleased that General Nesbitt and the governor saw fit to do this. In summary, just the bullet points I'd like to leave you with are the take-home messages that avian influenza is a health issue. It's not a food safety concern. Poultry is safe to eat if it's cooked properly, as we've all been taught to do. But this Asian H5N1 virus does continue to cause concern globally. The outbreak in domestic poultry is unprecedented. We have never seen such a disease that has killed millions and millions of chickens worldwide. But bird flu is vastly different from the pandemic influenza. And so we need to keep that in mind, that the bird flu is an agricultural disease. The pandemic is a human disease. The H5N1 detection in Georgia would result in a massive response to stamp out the disease, not only from our department, but our sister agency federally with USDA, the private sector, other state agencies, all that we could amass to come to our aid. Our department has developed a plan with input from many, many stakeholders for avian influenza, and we continue to make improvement as new information is known. One of the examples I used is the fire phone for euthanasia. So there are new technologies coming along every day that we are going to fold into our plan. But the state of Georgia, I would encourage this study committee to encourage our members in the appropriations process to invest in avian influenza preparedness for agriculture. There's been significant dollars on the human side, but yet little to none for the state of Georgia to invest on the agriculture side. A lot of what we have been able to accomplish has been through the generosity of grants from either USDA or our U.S. Department of Homeland Security. And so we really need to step up to the plate in the state of Georgia and invest in some of these resources that we need to continue our preparedness. Avian influenza really is our greatest challenge this century. We've been told not if, but when it gets here in the United States. And how unique to have this picture on the cover of the New Yorker magazine depicting this sick chicken crossing over to the human side. And this is what we're all preparing to prevent. The effectiveness of our response will directly parallel the economic damage to our poultry industry. So the more we can prepare, the better we can respond, the more we can protect this vital industry to our state. And we're going to be judged by our ability to rapidly detect it and contain it. We might not necessarily be criticized if it gets here because we know how easily it can arrive, but how quickly we find it and contain it is going to be critical for the state of Georgia. And last but not least, of course, is this sick chicken, as depicted in the front cover here, really is the cornerstone to protecting public health. The better we can eradicate it, the more quickly we can eradicate it from sick birds, the better we can protect the public health of that we're all charged to protect. So with that, I thank you very much for the opportunity to speak to you, to include agriculture in this very important work the study committee is doing on pandemic flu planning. And I think this indicates the importance of agriculture in that entire pandemic flu planning initiative from the very beginning of it. The more we can protect it from coming into agriculture, then the better we can ward off any mutation into a pandemic outbreak that would affect every one of us.
Thank you, Dr. Myers.
Thank you.
I really appreciate the presentation. I know that some of the members may have some questions that I do. If you can indulge us for a few
Certainly.
minutes. I've also been joined by Representative Burke Day, who's chairman of our Public Safety Committee in the House, and welcome, sir. And the members know he's an individual that this committee has leaned and will lean heavily on as we formulate our recommendations. And Burke, I invite you, we're a little shorthanded this today. If you would honor me by just kind of ex officio membership on the committee today, we'd welcome you up here to join us. And you can ask, yes, sir. That's what. Come on up. Come on down, Burke Day. You slide that chair over. Let me see. Any questions from the committee for Dr. Myers? Representative Roos.
One, I would love to get this slideshow on paper, if you could. That was very informative. The epidemic in California that you mentioned, I was trying to write and listen to. You said it came from a bird smuggled over from Mexico. Is that what you said?
That is suspected, yes, sir. Probably from a fighting rooster in Mexico. There's a lot of interest in those backyard birds in California, and you see quite a lot of them here too.
Yeah, I was kind of thinking it might have been a fighting cock, but I wasn't for sure. Did they ever find? Is there any legislation in California that is specifically would address someone who did that intentionally?
I'm not familiar with any. Dr. Arza, are you familiar?
Yes,
If I could have my colleague, Dr.
Sure,
Arza, to
sure.
answer. In fact, Dr. Arza was actually, he served as an incident commander in that outbreak in California, so he may have firsthand knowledge. Dr. Arza?
Yes,
I think you have to come to the...
yes, there is legislation to try to prevent that, but as it was mentioned, what is suspected is that the birds were smuggled in, and so it avoided the methods in place to try to prevent that.
Okay. So no one was ever caught, I guess, or punished for doing that? An individual?
For smuggling?
Yes,
Well,
yes.
Yes, and when that happens, and whenever we catch someone, then, yes, they are fined or punished accordingly, according to the authority that we have. But there's a lot more that occurs that we don't catch.
Right. Okay. Thank you.
Yes, sir, Representative Day.
Dr. Garner, it was a well-put-together piece here. I had a couple of questions, and I missed the first pandemic study committee meeting. You had some stiff competition, Mr. Chairman. That was my firstborn grandchild. So I did have my questions might have been covered in those meetings or during your presentation. First off, what are the methods that you have in place for detecting bird flu? And secondly, what is the procedure for communicating any detection?
I did cover that in part of my presentation. You may have missed that as far as the surveillance. Your first question was on detection. We have significant, robust surveillance systems in place in the private sector. The commercial poultry industry themselves have agreed to follow voluntary guidelines of the National Chicken Council. And they are testing collectively close to 25,000 samples a month through our Georgia Poultry Lab network system, of which we have about 10 labs throughout the state. And those labs are part of our department. They are funded through the legislature through our department. And so that is for the commercial poultry sector. On the non-commercial side, last year we tested significant numbers of non-commercial poultry at poultry sales. Most of those are on Friday and Saturday night. Some of the poultry enthusiasts bring a menagerie of waterfowl, gamecocks, pheasants, whatever to the poultry sales. Most of those are on the weekends, and they're growing. We have 50 extra sales this year that we didn't have last year, and we really think that's probably our highest risk population because those birds are moving around quite a lot, unlike the commercial industry. So we're putting efforts into the non-commercial. We could use some more resources. We're testing as many as we have the resources to test, but there's a lot out there that we're not testing. On the wildlife side, that is an initiative through USDA Wildlife Services, and they are partnering with the Georgia Department of Natural Resources to conduct surveillance on wildlife.
Would that include migrating birds?
Yes, shorebirds and migratory waterfowl.
Thank you.
And I believe you had a second question, or did I answer?
Well, if you detected something, who would you
Yes.
forward that information to? What is the procedure?
We have gone to great lengths, and I didn't cover that in the amount of time. We could spend 2 weeks or more talking about this subject alone. But in our plan, we have laid out very detailed flow charts of what would happen in the first few hours, what would happen in the first few days, then what would happen during the remainder of the outbreak. And because we have learned, as you questioned, indicates that those first few hours are very critical to get the correct message out to the decision makers. So when we
First call would be to whom?
This man sitting right here.
Mr. Irvin?
Commissioner Irvin.
And then he
In
would-
those first
you would
few
call-
hours,
You would advise whom?
I advise the governor and the Secretary of Agriculture in Washington. In an outbreak of this nature, we'd ask the governor to inform the president.
so in this plan, we have specifically what the Commissioner of Agriculture would do, what Dr. Arza would do, and what I would do. And our first call would be from the laboratory that would tell us the national laboratory has to make that initial call to us. We would immediately notify the commissioner. But there's a little twist to this in that we may not know it's the highly pathogenic strain for several days, possibly up to 10 days, because the laboratory can detect whether it's an avian influenza virus, but in order to detect it being a highly pathogenic virus, they have to go through pathogenicity studies on live chicks. So the Secretary of Agriculture will not declare a state of emergency until he knows it is the highly pathogenic strain. So there's a window of time there for 10 days that we don't have the Secretary's declaration, that we have to muster what USDA resources we can garner, and we'll be heavily reliant upon state resources. So it's critically important that we have those state resources from the get-go, especially those first 2 weeks. So that call from Commissioner Irvin to the governor's office to ask him to garner those resources that we need is going to be very, very important.
One final question, Mr. Chairman. Yes, sir. Do you know whom the governor's office would then contact? Would it be somebody in Homeland Security? Would it be somebody in GEMA?
With the governor's declaration, or?
I guess I'm curious about the chain of communication. And if you don't, I can find out, another way.
Commissioner Irvin would make the call to the Governor Perdue's office, and then we would be working underneath that with, yes, the Georgia Emergency Management Agency, the Office of Homeland Security, all those other agencies I listed there. And in fact, we will ask the governor to activate the State Operations Center, which will serve as the central command for helping the Department of Agriculture respond to this outbreak. We would ask the governor, backing up to agriculture, the commissioner, as he mentioned, would also notify the Secretary of Agriculture. Of course, the Secretary would likely already be informed, but that we needed all the assistance we could muster from his agency. Governor Perdue then would also likely notify the president, because this would be a foreign animal disease. It would be economically devastating to our state. And so we would try to ask the president for assistance of other federal agencies, such as the Department of Interior, and possibly the FBI and other, maybe even the military, if we needed those resources. So we would want the president to know that we were asking him to release the federal resources we need to contain it. So I think if you're interested, we can send you that portion out of our plan that details those very specific notifications.
You might also explain to him how the quarantine would work.
If you're interested in the quarantine, the Department of Agriculture has the authority to quarantine premises with animals on it. So as a part of this, when we initially found any detection, we would quarantine those premises immediately, which would prevent any animals from moving onto the property or off of the property. We would dispatch a foreign animal disease diagnostician, which is a specially trained veterinarian, to go onto the farm to do an investigation. What do the birds look like? Do the clinical signs, are they consistent with avian influenza? To take the appropriate samples and send them to the national laboratory. And you saw that picture there of the significant geographical area this would undertake. So when you've got a 50-mile swath and you're going farm to farm with a team of veterinarians and animal health technicians, you need a lot of resources. And that farm would stay under quarantine until we are assured that either the farm was negative, or if it was positive, that all the birds have been depopulated that were infected, that the premises have been cleaned and disinfected, the birds have been properly disposed, there was no more risk of the virus being on that farm, and then that quarantine will be released. But that quarantine could be in place for weeks, possibly months.
Thank you, Dr. Myers. We appreciate you coming today, and thank you, Commissioner Irvin. Just moving right along, and I will share with you, just for the sake of our speakers, we have what the committee has accomplished so far. We held an initial meeting here in the Capitol a few months ago, and we talked a great deal about the various scenarios that certainly are possible, and boy did we cover them, from the range of this isn't the one, it's not going to be so bad, to everybody's in real trouble and we don't know what we're dealing with, and it's Spanish flu all over again. And we've got a pretty good history of what that has looked like in the past and could look like as far as the tragedy of a pandemic. And then we went on to moved into kind of our concern as a state economically, and our poultry industry. As we've all heard this morning, I guess we're approaching about a $5 billion industry here in Georgia is poultry, and so our concern as a committee moved towards that, and we visited a very large poultry farm in eastern Georgia, where we learned some good stuff, and we're very happy to see that, in fact, our chicks are being raised indoors in a very sanitary environment, and the committee, I think, was very pleased with what we found. We didn't enjoy wearing the suits they put on us, but we did have a good visit, and we're very happy with what we found as far as sanitation and management of those birds. So with that in mind, we're going to move on to Dr. Pat O'Neill with DHR, and welcome your comments, and certainly we have some questions for you.
Thank you, Mr. Chairman and committee members. It's a pleasure to be able to speak with you about a topic that's not so pleasant. Before starting, though, I'd like to mention that with Dr. Myers, we have a very valuable asset in Georgia. Dr. Myers was part of a group that attended a Homeland Security conference in Israel back in March. I was on that trip as well, and while we were there was an actual outbreak on a turkey farm. And Dr. Myers had firsthand experience witnessing the depopulation that took place then, and so she's speaking from great knowledge as she reports on these issues. In terms of the participation in pandemic planning by the Division of Public Health, I should mention that we're doing this primarily under our responsibility through Emergency Support Function 8. This is the function that requires public health and DHR to assure health and medical capacity during any type of disaster. And obviously, we don't think that there's much in the way of disaster that could be worse than pandemic. Possibly nuclear holocaust, but other than that, I don't think there's anything that's more comprehensive. I would like to emphasize what Dr. Myers had also said, though, that it's really important that we distinguish between bird flu and pandemic influenza. And pandemic influenza, although it could arise from this particular H5N1 strain that's causing the bird flu, that's not necessarily the case. There are other options as well. There's some assumptions that are extremely important, and I'm sure the committee has probably addressed these or had these addressed by other speakers, but I think it's important to underscore two major things. And these are what we do not know. We do not know when the pandemic is going to occur. And we do not know how severe it's going to be. We are asking folks, however, to prepare as though it would be as severe as the pandemic of 1918. But we don't know that that's going to be the case. Why are we doing this? Well, I think certainly in public health, we tried to look and learn from the experience during Katrina. And one thing that I think we learned was that in our planning, we need to be preparing for worst-case scenarios rather than middle-of-the-road scenarios. Plan for the worst and hope for the best is essentially the way we're working on this. On this particular slide, the first assumption that I mentioned there is terribly important, and that is that we already have in healthcare major shortages of personnel, particularly nursing, lab techs, x-ray techs, pharmacists, across the board. But nursing is the shortage that I think is most troubling. When I prepared this slide, I was thinking primarily of public health's responsibility to support the healthcare delivery system. And I was concerned that we already have shortage of hospital nurses as it is, nationally about 16%. We expect probably as much as a 40% absentee rate during a pandemic. And there is certainly a possibility in healthcare that the exposures are going to be even greater, so the percentage of absentees may be greater as well. This was my major concern as I was preparing the slide, but since then I've had chance to actually expand that to another area. I'm going to be talking later on about public health's role in trying to support the health delivery system, and I'm going to propose a home care model that we hope to use. But that model is extraordinarily dependent upon public health nurses. I think the shortage now bothers me as much, maybe more, with public health nurses as it does with hospital nurses. Right now in the division we have roughly 1,579 nurses, give or take a few. Between 2003 and 2005, we lost 215 nurses. Already in 2006, we've lost another 18. If the loss continues at the rate that it's going now, unabated, within about 7 years, we'll be down to zero. And our ability to support the healthcare delivery system with the home care model is basically with our nurses, who may not be there. We are concerned about surge capacity.
Dr. O'Neill, can I ask, just so I don't forget it, a question on
Sure.
that, Mark? Is that primarily the shortage and the decrease due to funding or just a normal attrition, folks?
It's primarily, we think, based on a lot of interviews with nurses. It's based on a difference in salaries. Public health nurses are leaving to accept other positions in hospitals that pay as much as $20,000 to $25,000 a year more. Surge capacity is something that in our planning we have been asked to address through the federal grants that Georgia has received. And basically we have identified that there are a lot of surge beds available in Georgia's hospitals. And I'll let you look at some numbers a little bit further down on the slides. What we haven't really addressed satisfactorily, though, is how to staff those beds. And if we create more beds and have less staff, I think the outcome becomes pretty obvious in terms of a diminution in the quality of care that's going to be available. We are suggesting, based on modeling, that with most pandemics you can expect an attack rate of between 30 and 35%. With Georgia's population roughly 9 million, this means we should expect at least 3 million folks would succumb to pandemic, not succumb, but would become ill with pandemic. By week 6, this would mean that there would be 6,000 hospital admissions occurring just from pandemic.
You must be giving good remarks because the questions come up as you go. I hope that's okay.
Sure.
If you don't mind, I'm like the chairman. If I don't get a question out, I'll forget it. I'm thinking of nurses and I'm thinking of volunteers. What is the total expectation of a nurse under your scenarios?
A public health nurses, you're asking?
Yes, sir.
My expectation, I'll talk a little bit more about further on, but it's basically going to be a home care model that I'll explain to you as we go through the slides.
Is there room for volunteers?
Yes, absolutely.
Thank you.
I think most of you have probably seen this photograph related to the 1918 pandemic, and essentially it shows what was the surge response back in 1918, using large facilities and putting cots in there and just having folks spread out through there. You can imagine what the ratio of caregivers to patients was in a situation like that. And you can also imagine what the contagiousness of that general area would become. I think this slide is important for us because it's looking at numbers based on models that would be pertinent just for Georgia. Essentially, this is looking at a 30% attack rate. As I mentioned, many models go up to 35%. So we're expecting somewhere between that 2.7 and 3 million ill individuals. We think, again, based on previous pandemics, that about half of those patients could be treated on an outpatient basis and not require hospitalization or ongoing care by physicians. We would expect that about almost 300,000, however, would require hospitalization. And of those, a significant number, roughly 44,550, would require intensive care. 22,275 would require mechanical ventilation, and we would be faced with over 57,000 deaths in Georgia. Those numbers, I think, are staggering when you look at what our current healthcare system has available. In Georgia, we basically have about 16,000 beds available at any point in time. There are 23,000 licensed beds, but many of those are for special procedure purposes. They're not for general admission purposes, or they're not staffed beds. So we have 16,000 staffed beds. We've identified 12,000 more surge beds that could be brought available if need be, but no additional personnel to staff those surge beds. What we're doing in terms of our planning is essentially to have the oversight of all the planning handled by a statewide pandemic coordinating committee, which actually had its third meeting last week. It meets roughly quarterly. And this is a multidisciplinary group of about 35, 40 people altogether who are participating in the planning process. And we're doing this in response to a request from HHS Secretary Michael Leavitt, who had suggested that a lot of the planning that public health has done in the past for pandemic has been too much in a silo. It's been an epidemiologic approach to planning for pandemic, and it's looked at pandemic as a public health emergency, which obviously it is. But what it has not looked at is the fact that pandemic is also a societal emergency that affects every single segment of society. The economic impact, of course, can be overwhelming. In addition to the state-level committee, we have asked that there be local planning taking place. And right now we have 31 local planning committees throughout Georgia. They too are multidisciplinary and essentially have the same types of folks represented on there. Obviously public health, the healthcare community, public safety is represented, transportation is represented, education is represented, the faith community is represented, business is represented, perhaps more importantly than on any multidisciplinary group in the past. The goals for Georgia's plans are listed here for us. We hope that every resident will learn how to protect himself or herself. And I can't underscore the importance of individual responsibility and accountability. When we are in a full pandemic situation, we are going to be beyond the ability of the feds to come down and help us. We're going to be beyond the ability of the state to go down to the regions or to the local areas to help. So it's going to be critical that the knowledge of how to best protect oneself reside with the individual and individual families. We want the systems to be in place to care for large numbers of patients, systems in the hospital setting as well as systems in the home setting. It's very important that essential services be maintained. And we're asking businesses to identify all aspects of their particular businesses that are essential and come up with plans for how those essential services can be maintained, to identify critical infrastructure and to plan for maintenance of that infrastructure. We know that there will be economic disruption, but we think that with careful planning, that disruption can be minimized. Assuring that patients have access to appropriate medical care, again, is a public health responsibility during disasters. Typically, that access is seen here. Folks have a problem, they may call an ambulance, be taken to an emergency room, or they may have a problem, call their doctor and go to the doctor's office or go to a clinic. If the problem is great enough, they may go into the hospital setting. This is a summary of the surge capacity planning that we've done. As I mentioned, we've identified a total of 12,000 surge beds. We have purchased some 4,000 portable beds and cast those around the state using federal money from the HRSA grant. We will be continuing to purchase additional surge beds, hopefully up to the 12,000 that we have space for. We are also in the process right now of trying to purchase portable hospitals, inflatable hospitals, that can be put up generally adjacent to or on the grounds of other hospital facilities to augment the bed space of those facilities.
Doctor, just real quickly.
It looks like a gigantic tent.
What do you do in there? Is it full service? Hospital?
Yes, there are various ones on the market. The military has the greatest experience with these. We are looking at ones that can be erected very quickly within 90 minutes. Essentially, we are looking at 50-bed facilities that are portable. We intend to station these in each of the 18 health districts around the state. They can be kept within a given district, or they can all be pulled together and form a 900-bed facility if need be. I do not. I can tell you that the range for purchasing 18 is anywhere from about $400,000 to a couple of $1 million. Yes, except for the personnel. It does not include the personnel.
Is it like, you know those things you sometimes see with kids? You blow them up and then they have little balls on the inside of them, but the walls are inflated. Is it architecturally similar to that?
Yes, similar to that.
But without the balls, I assume.
Right. And they have their own power supply. They have the capacity for negative pressure to minimize the risk of contagion. And they are controlled in terms of temperature, so they're quite useful facilities. In-home case management is the area that I have great concerns about. We anticipate, as I mentioned, that about half of the patients in a pandemic could be cared for in a home setting. And it's in order to protect the hospital setting, which is already going to be terribly overwhelmed, being able to adequately care for those who can be cared for at home is really critical. And what we are envisioning is a telephone triage system such that folks could call a single number and be triaged by a nurse using a protocol to determine whether or not the patient was a candidate for home care or if that patient needed to be seen by a physician or a nurse practitioner. If the patient is a candidate for home care, then we anticipate ongoing case management by the public health nursing staff on a regular basis to manage those cases, and if in fact the patient's condition changes, make recommendations to seek care either at the hospital or through a practitioner. I'm going to just quickly flip through this because this gets kind of down into the weeds, talking specifically about the in-home care system. I think this comment by Levitt is very important, though, and I want to emphasize it again because it gets back to the point of individual accountability and responsibility being so crucial here. Any local government that fails to prepare for an influenza pandemic, expecting the federal or state government to bail them out, will be tragically wrong. The thing that is so unique about pandemic influenza as compared to almost all other major disasters or emergency situations that we deal with is that the concept of mutual aid goes out the window. Early on, mutual aid can be an important part. Early on, the role of the feds, the role of the state can be very helpful. But once the pandemic is full-fledged, every aspect of society is impacted, and there's no slack any place. There's no ability for the feds to come down. There's no ability for the state to go down to the local level, and it's going to get back to the individual's ability to survive. Identifying and coordinating local community health care and support services and resources is extraordinarily important as we continue our planning process. And we, as I mentioned, are looking at all avenues for trying to essentially expand the capacity at the local level.
Dr. O'Neill, I'm sorry, you continue to inspire questions as you go along.
Sure. I am inspired. Dr. O'Neill, you mentioned about local communities and saw the quote just a minute ago on the board. Is there any way to help local communities? 'Cause I'm sure a lot of them are probably not even thinking of this. They're more worried about zonings and those kind of things. Is there any way, a package or any way y'all could help them kind of get started in thinking, on what to do so they don't have to depend on the state or feds?
Yes, I think the single most important thing is the educational piece. And if I had to fault the degree of planning that we've done thus far, I would tell you that I think that it's because we have not done an adequate job of sort of the pre-education piece. We are pulling together these local planning committees, but we are having a hard time getting engagement. And I think the reason that we're having a hard time is that many folks do not perceive that the risk is as significant as it is, and many folks do not have any concept of how comprehensive a pandemic will be. There are plenty of other things going on, obviously, that are troubling, that keep folks' attention. Pandemic is kind of down on the list. There is going to be a major educational campaign on the federal level, which will be pushed out not this year, but next year. If I were redoing what we've done, I think I would have emphasized much more the need for that educational piece on the front end in order to get the engagement for planning. I know that the planning will continue, and as the educational piece is unfurled and people become more engaged, the plans will change, the plans will continue to mature. There are tremendous gaps in our plans right now. They're nowhere near final, and in fact probably never will be final. I think that this type of planning is something that matures, but it never really finalizes. You constantly change it as time passes. And again, the issue that's problematic for me is that I don't know when the pandemic is going to hit, nor does anyone else. So if we do get the engagement of the public, and the pandemic doesn't strike in a year or two or three, how do you maintain that engagement? How do you maintain that alertness and that awareness and that participation?
What I would like to do is, let me back up. So if my local communities contacted you, is there anything they could get now if they chose to be proactive? I mean, I'm all for giving them the opportunity, and then it's up to them whether they take it or not.
Yes, we have put together several planning kits that we're making available to the local communities. All of the ones that have the local planning committees in place already have these kits and are using them. The CDC has been extremely helpful in preparing what they refer to as checklists for various different sectors. Local government is one sector that they have a checklist for to determine how prepared you are or where your gaps are. There are checklists, there are kits for the business community, for the education community, for the faith community. I think we now have about 12 different sectors for which we have put together kits. And these kits essentially will give the sector a checklist to determine where they are right now and where they need to be, as well as some essential ideas of what they need to be perhaps stocking up on in order to be prepared, and for how long they need to have certain things available. In the event, for example, that within 3 days we anticipate that the shelves of the grocery stores may be empty. So we're recommending that there be food supplies that can be rotated and can be kept by individuals and families. And there has to be preparation for those that don't have the capacity to do that. The faith community is helping tremendously to reach out to those folks that don't have personal capacity like that. They would call their district health director first. This list here shows the importance, I think, of reaching beyond the healthcare community and the typical partners that we have in healthcare with public safety and with health providers. But we also need, as we're doing this planning, to pull in folks such as the media, because they're going to be so crucial to the educational piece that's going to be coming down on this. Businesses have an extraordinarily important role here. Businesses make up, many businesses have essential parts of critical infrastructure that, if lost during the pandemic, will have a tremendous negative impact on society as a whole. So meeting with those businesses and being sure that they've identified their critical infrastructure and have the ability to maintain that is really crucial. The utilities have been extraordinarily proactive with this. I'm pleased to say that probably the best planning I've seen has occurred in our large utilities and telecommunications companies. Schools are going to be extraordinarily important in this, because we're going to be looking at social distancing as a way to contain the pandemic, and closing down schools early on is going to be an important part of that. So working with the school community, the educational community, will be extremely important, and already has been. Transportation systems are also going to be extremely important, because we have a society worldwide which doesn't have large inventories. We depend upon transportation to transmit goods generally within a couple or 3 days of when the supply runs out. So trying to determine how we maintain essential transportation during the pandemic is going to be crucial as well. Yes.
In looking at your first line there, that the committee with all the counties, are locally elected officials included in that?
Absolutely.
I mean, that's good. We've had a number of other scenarios with different topics where they're there seems to be just a lack of consistency in having them at the table. And good move. Thank you. That's a great move.
The purpose of the planning kits that I mentioned is listed there for you. Obviously, in the kit, we want to educate the individual as to what their responsibilities are and what they're going to need in order to survive during this. Continuity of planning is a piece of this. And the need for and where it can be found in terms of community support services will have to be there for individuals to stay isolated, particularly when we're dealing with special needs populations. We're going to have community resources that can support them. If we're asking them to stay isolated, there has to be the ability to get food and necessary aid to them in whatever the location is that they're being asked to stay isolated. And I think we've been through the role of the local planning committees, the kits. Again, this is kind of down into the weeds, so I will check through this real quick and get to this. Lingering, challenging questions. I think with our planning that we've done thus far, we've made a lot of progress. But, and this is a big but, we're nowhere near where we need to be. Our planning has identified tremendous gaps in readiness that have to be filled. It's going to probably take us years to fill these. Hopefully we'll have years before the next pandemic strikes to accomplish that. The issue of stockpiling is a very important issue, and one that may come before the legislative group is stockpiling of antiviral drugs. I'm sure you've probably heard that the federal government has provided, without any charge to states, on a population basis, a cache of antiviral drugs. Georgia's portion was 1.2 million courses of antivirals, not doses, but courses, essentially 10 doses per course. We have the option, in addition to what was provided by the government, of purchasing up to an additional 910,000 courses, where the feds pay one part, we pay 3 parts. The 910,000 courses, if we purchased all of our allotment, would cost the state roughly $15 million. A recommendation went forward from the Division of Public Health to the Commissioner of the Department of Human Resources, which was forwarded to the governor, that Georgia make the purchase of the full allotment. So far, 33 states have already placed orders on their allotments. 4 states have decided not to purchase any of their allotment. Out of all the states, 4 have made the decision to purchase none. Our recommendation from Public Health was to purchase the full allotment. That would bring us up to a little bit over 2 million courses, which is still far less than what we would actually potentially need. Now, there are great problems, however, with the purchase. One is that the shelf life of those antivirals is only 5 years, unless it can be extended. The federal purchase that was given to Georgia and will be kept in the Strategic National Stockpile will have the ability to be extended through the Shelf Life Extension Program. So far, the drugs that are being purchased by states are not covered by this. So 5 years is all that we know that the drugs would be good. The antivirals happen to be very stable, and the likelihood is that it would be extended anyway if we didn't need them within 5 years, and say 7 years down the road we did need them. But officially, 5 years is the shelf life. So that's problematic since we don't know when the pandemic is going to strike. The other problem is that we can't guarantee that the particular antivirals that are purchased will be effective against whatever the pandemic virus is. We think that there is a strong chance that they will be, but we can't guarantee that because we don't know what that virus is going to look like. We think that it probably will have a good chance of looking like the H5N1, but we don't know that with certainty. So we're recommending a $15 million expenditure for a drug that may actually run out on its shelf life before it's needed, and which we can't guarantee is going to be effective against whatever the bad virus is. That's the problem for us.
That's a problem. If you're do you vote for that budget?
Yes. I asked the state-level pandemic coordinating committee the same question last Thursday at their third meeting. Unanimously, every member voted in favor of the purchase, even with those unknowns.
The 5-year shelf life.
The FDA.
I'm wondering what the difference is. We attended a conference in Louisville, Kentucky, and somebody from the federal government, in answering the shelf life question, they said it was virtually unlimited. I don't know if that came from the CDC or from whom, but there's an obvious discrepancy in how long it lasts.
I think the discrepancy is probably more technical than anything. The FDA establishes a shelf life. With this particular group of drugs, we know that those drugs have great stability and would be effective generally well beyond 5 years. We don't know exactly how much longer, but we know that they would be effective considerably longer. If temperature and humidity are controlled, you can have a drug that qualifies for the federal shelf life extension program, which is what those drugs that are being kept in the Strategic National Stockpile will be part of. Those shelf lives will be considerably longer. I don't know that they would be infinity, but they will be longer. But the ones that we purchase, from a technical perspective, would have a 5-year shelf life, unless there is some opportunity later for the purchases to be covered under the federal shelf life extension program, which is something that the Association of State and Territorial Health Officers is asking for. Right. Now, when will there be a vaccine? That's another big question. It takes roughly 4 to 6 months to build a specific vaccine against an influenza virus. And since we don't know what the virus is going to look like after a mutation that makes it pandemic, you can't build it until that occurs. So we would be 4 to 6 months into the pandemic before we would have a vaccine. And then we would have the issue of building enough of that vaccine for the remainder of the world population that had survived beyond that 4 to 6 months. Right now, the federal government has a vaccine that they are stockpiling to H5N1, to the first clade. It was built on some of the early samples of the H5N1 in Southeast Asia that crossed over to humans. The theory being that even though that's not a specific vaccine, that it would offer some degree of immunity, such that probably a single booster shot of a specific vaccine would give excellent protection, and you would get partial protection even with the non-specific H5N1 vaccine. So far we have 3 million doses in the stockpile, and they are building more. Now, if in fact we are talking about over 80 million people ill in the United States, we're talking about a total population that might need vaccination of well over 300 million, and we've got 3 million doses stockpiled. Obviously, we're far from where we would need to be with a vaccine. One of the great concerns is that the countermeasures that we are so accustomed to, vaccine being the best for viral diseases, and antivirals being second best perhaps, we may not have adequate amounts of either of those countermeasures for the bulk of the population. And if we have any at all, we may be forced to prioritize who gets them. And defining those priority groups is going to be a question of extraordinarily difficult proportions. The role of cats. Dr. Myers mentioned that, in fact, H5N1 had been identified in cats as well as a dog. We do not know of any instance where cats have actually transmitted it back to humans, however. So we don't think that that's going to be a likely vector source.
Prone to being carried in and out by a cat?
Right, that it's not prone to going from a cat to a human, whether it's an inside cat or an outside cat. The ability of the cat to transmit it to the human just doesn't seem to be of any great significance.
All right, let's say a migratory bird flew over a place in Florida and defecated, and in the backyard, and a dog or a cat, typically an indoor pet, goes out to that area, gets it on its foot, carries it back into the house. That's not a concern?
It could be a concern. We haven't had any cases that have been identified like that so far. The cases that have, I think, been of greater concern have been where cats have actually partially eaten dead birds that had died from H5N1 in Europe. And in none of those situations where the cat became ill with H5N1 has the disease been transferred onto a human from the cat.
Feces?
Correct. None that we've identified thus far. Risk of waterborne transmission is something that is being looked at, and we don't have good answers on that at this point. The containment measures that we are looking at are basically primarily social distancing and voluntary in nature. We do not anticipate that mandatory quarantine will be a significant value in this situation. The problem with influenza, the greatest problem, is that you may transmit it for probably 12 to 18 hours prior to becoming symptomatic. So being able to quarantine folks, it's going to be hard to identify those that should be quarantined. The question of closures of schools and businesses is one that we're grappling with at the state level, and we are hoping to have recommendations at the state level so that there can be consistency across the state rather than doing it independently where you may have a school closed in one area and perhaps just a few blocks away another school will not be closed. We're concerned about the chaotic reaction of the public to that type of inconsistency and closure. And we're hoping that we can come up with some recommendations such that there will be consistency in all the closures. And if we succeed, we cannot stop the pandemic, but we can delay the epicurve. And that's of value to us, because if we can delay it, we can better utilize the facilities that we do have available in healthcare. If we have suddenly massive numbers of folks that are affected, understand the 16,000 beds plus 12,000 surge beds with limited personnel to staff those beds aren't going to be able to handle it in Georgia, nor anywhere else in the country. It's not just Georgia. This is a nationwide issue and worldwide issue. We can diminish the peak impact on healthcare resources, and we can decrease the overall impact on society. But we cannot stop it. It is going to happen. We just don't know when. And again, we don't know how severe.
Asking you questions is a great idea.
You was talking about school closings a while ago and how that, would that be like on a regional basis, or you have any idea on that? Or?
Yes, I think it probably will be. We are working with the educational community to try to figure out what the triggers will be and how we will implement those triggers and within what regions that will occur. Will it be regional within Georgia, or will it be statewide? I can't tell you right now. My suspicion is that it will probably start out regionally within Georgia, and within very short order there will be certain triggers that will make it go statewide.
If other
Cases were diagnosed throughout the state.
Yes. We expect this pandemic to spread much more rapidly than the 1918 pandemic. Obviously, with transportation such as it is nowadays, it's going to be worldwide in no time. Now, we do have, I think, an advantage in using quarantine very much in a limited fashion early on. And we have exercised a plan at Hartsfield-Jackson such that if we are alerted that an individual, let's say, who has boarded a plane in Taiwan, who was fine at the time that they boarded but became ill en route to Atlanta, we will quarantine that entire load of individuals that are arriving for 10 days. We have a special hangar set aside for that. We can care for those individuals for that period of time, and we plan to do so. Again, not that that's going to stop the pandemic, but it may slow it.
If I may ask you, as I asked the previous presenter, let's say that you were to detect an infected whatever, and it's overseas or what have you, it's on its way here in a shipment. What is your line of communication? Who do you first contact if it involves a quarantine situation?
Actually, if it involves a quarantine situation at Hartsfield-Jackson, the CDC has the quarantine station at the airport, and they will be notified probably even before I would be notified. As soon as there was a call from a pilot into the tower at Hartsfield-Jackson that they had a potential individual who was infected, they notify the quarantine officer at CDC. In turn, that individual would notify the state health officer, Dr. Stuart Brown. And that starts the chain. Dr. Stuart Brown sits on the Homeland Security Task Force, and the call goes from him to the task force, and from there to the governor.
Doctor, I'm sorry.
The Ag Commissioner reports directly to the governor's office. CDC would contact Dr. Stuart Brown,
Right.
who would then contact the governor.
Right. Now, the likelihood is that CDC would also place a call to the governor at the same time that they were notifying Dr. Brown.
Is that a yes?
Yes.
Okay.
Well, Dr. O'Neill, we thank you very much for your attendance and a very informative presentation.
Thank you.
And if I could ask you just to indulge the committee on getting a copy of that PowerPoint, we'd really appreciate it.
Sure.
That Meredith Cagle in the red dress seated over there, she's probably can give you an email address, might be the easiest way to get it to us and save you some printing costs. So,
Be happy to.
thank you very much.
Thank you.
Moving on, guys, to the, and gentle lady, to the private sector. We've heard time and time again how important the private sector is and is going to be in dealing with a pandemic. We have just an additional agenda item that I want to slip in very quickly. Some folks representing our biotech science industry here in Georgia. I know I saw David Berryman. David's still there. And they're joined by Thomas Hodge and Lizette Fernandez. Is she here as well? No. If you two gentlemen want to come forward and just give a few remarks, and the committee ask you some questions, we'd really appreciate it. And obviously, for the sake of time, if you guys can limit your remarks to the really good stuff, we'd appreciate that too. Thank you.
Like I said, the private sector gets 5 minutes, huh? Is that what you're telling me? No. Thank you, Chairman Cox. Appreciate it. I've had an opportunity to meet you and have been very impressed with the things you're doing. So it's nice to talk to y'all. Just as a little bit of background, I'm a Georgia guy, undergrad in genetics, University of Georgia, and then I got a law degree from the University of Georgia. Went away, was in the biotech industry doing patent law, and along the process starting companies in biotech patent law. One of those companies has been acquired by a public company, another just went public, and a third is kind of the focus of what we want to use as an example here of what the private sector is doing and could enhance in the state of Georgia. So a lot of the talk, is about reactivity. What do we do when this happens? And then some of the talk shifted nicely to, well, what's the proactive side? What are the therapies that we can bring? What are the vaccines that we can bring? And I think we just heard that that's not ultimately very satisfying. The vaccines, who knows what the emerging pandemic is going to be, what the virus is going to look like. So how can we possibly design something in advance to stop that? We can't. We can guess, maybe slow it down. That's what we heard. Antivirals, they don't really work very well. Maybe you can slow it down a little bit. Maybe you'll have flu for a few less days, but they don't shut it down. So in that problem, then, I think industry can step in and give us some options to really make a difference. And I was lucky enough to be involved in a technology, as an example, which sort of relates to a paradigm shift. And this is the company that we ultimately formed around this, called Avatar Biosciences. Started out of Vanderbilt. When I saw this technology, I called Tom Hodge, and so we had barbecue at Fat Max over it. Tom was at the CDC, researcher, a chief in the immunology, HIV branch there. We started talking about this. And so what this paradigm shift was we're not talking about vaccines. We're not talking about traditional antivirals, and that's not very traditional because they hadn't been around very long. But we're not talking about things that go after the virus and the immune system. What this technology did is it allowed you to know all the cells in us, our cells, that the virus uses to make itself. These viruses are little genomes. So they don't succeed unless they exploit our genes, our proteins, to make more of themselves. And so this technology that we've brought to Georgia is a technology where you can shut down those genes. So when the virus comes in, these viruses are using common pathways. They're using a lot of the same proteins, a lot of the same genes to make themselves. So whether you have a pandemic that is a flu strain, or say a terrorist, okay, technology is very much out there right now for a terrorist to take a conventional bug, easily engineer it. Technology's out there. If we've stockpiled vaccines, if we have traditional antivirals, they're not doing any good against that. And so unlike those technologies, this technology, and I'll let Tom talk a little science to you, is about shutting down common pathways that all these viruses would share, whether they're engineered or whether they're pandemic. So we're tremendously excited about this as an example of what's going on in Georgia. And those provide really, the hope for the future. Now, these aren't, some of them are getting close, but these aren't things that are going to be around in 6 months or a year. But, we've been this long and we're all still here. So thinking about things, about the state, about technologies, about industries that's here that we can help, however, either through funding these sort of things with state money, or just general infrastructure support, or just knowing that y'all are behind it, is a tremendous boon to these sort of things that really have a chance to be the big difference, I think. So Tom's also from Gainesville, Georgia, one of the epicenters of the poultry industry. So I call him the good old boy curing really bad bugs. So with that, I'll give you time.
Thank you, David. Thanks to the committee for allowing us to speak today. As David said, basically it's our opinion that vaccines don't work,
and the antiretrovirals or antivirals that are out there right now also don't work very well. Tamiflu, for example, there's already reports of resistance emerging for the Tamiflu against Asian flu or against flu in general. Vaccines, you are behind the curve when the bug hits. You've got 4 months to make it, and sometimes it still is not right. The problem we have with high path flu is that the traditional way of making the vaccines is going through duck eggs. You passage it through the duck eggs, and in this case, the high path flu kills everything, so it's very difficult to make the vaccine. That's why they're having so much trouble. So about 4, maybe 5 years ago, David comes into my office at the CDC and says, tell me why this technology won't work. And it's absolutely a paradigm shift. For years we've gone after vaccines. We've gone after trying to fight the viruses themselves, like with antiretrovirals for HIV. And while they do work a little bit, it does not cure the virus. We've known about viruses, I guess, since about 1895 when they discovered tobacco mosaic virus, of all things. And we have yet to cure one person with a virus infection. Pasteur came pretty close because he treated a boy with rabies using a vaccine, and it did clear lucky for him, the virus is very slow. Now with things like flu, you have a very acute stage, is high path, and you will, for the most part, succumb to it. So the shift that we've taken, and I left the CDC to go to the University of Georgia. I'm now based at the ARC, the Animal Health Research Center. There are 4 of us in our teams, and we have state-of-the-art BSL-3 Ag Plus facilities, as you probably know about this. And I went there purposely. I was actually endowed with a private endowment of $1 million to take the money and take this technology anywhere I wanted to go. And I wanted to stay in Georgia because it's where I grew up and I love it. And I think that we can do the work that we need to do in Athens right now. We started out with HIV, and we have found a way to actually stop HIV. We can keep it from integrating into the genome. And the very interesting thing about this is there's already a drug out there on the market for this, not for HIV, but to treat other indications, in this case proteinuria, which is associated with a diabetic or kind of kidney disease. And so we're in negotiations with 3 different pharmaceutical companies to try to get this to work into phase 1 or 2, actually be phase 2 clinical trial, because they're already past the animals and the toxicity issues. But it does look like it works pretty well, actually, and keeps the virus from integrating. And it's a drug designed to treat something in the cell. It's not going after the virus. The problem you have with many of the antivirals, particularly with what we call the heart therapy, which is a highly aggressive antiretroviral therapy, is a combination of drugs, and they're given over time in mix and match kind of thing. And the viruses, as you know, mutate, become resistant, so you have to shift and try other drugs. In this case, we think that there's going to be very little opportunity for the virus to replicate. To mutate, because it will not be able to replicate, so you don't have a mutation. And in this case, the drug does not actually come in contact with the virus to enable that type of resistance. We've also found, about 2 weeks ago now, another drug that is able to shut off pox, herpes, and a friend of mine tested Ebola, and it works for the hemorrhagics. Now, these are drugs that are already out there that nobody had any clue that they were going to work, because they didn't test them and they didn't know that this is the approach. As I said, people have approached this problem by targeting the virus. This targets the cell. It targets different proteins in the cell that the cell doesn't necessarily need. It can get around it. Sure.
First off, and again, Mr. Chairman, maybe I missed this part before. I don't know anatomically how, from exposure to infection, I don't know all the different stages that goes to. Mm-hmm. But if I'm hearing you correctly, let's say, does it impact muscle? Does it impact muscle cells?
It can. Basically, with what happens with any particular viruses live inside our cells. Okay, they do not replicate outside. They require the house, which is a cell. And they come in with very limited nucleic acid information, very small genome, as David said, which means that they're relegated to using and hijacking, if you will, the cell. So they use different proteins, they use different cell organelles. Sometimes they integrate into the cell, sometimes they don't.
So the mitochondria.
That's right, or the nucleus, and then they replicate and make tons of, in the case of polio, for example, it's mostly neurological. It's a neuromuscular kind of thing, so it moves up the nerves and the muscles. With the case of these are systemic drugs. This is like taking aspirin. They would be all over the system, so it really doesn't matter what the cell is. Absolutely. That's right. We've already started, and we've tested the drug for pox in animals, which was used for something else, and I can't really tell you what it is because our patent attorney would take me out into the woodshed. But basically, we've tested this in mice, and we blocked pox using a very minimal dose. We were able to show that we could stop. But this is cowpox. We don't work with smallpox here. This is only the CDC and a place in Russia that lets you do that. But they're basically the same organisms. And we shut it off, and the mice have lived an extra 2 or 3 days longer. Very minimal dose. That's systemic. So you put the drug in IP in the belly, and you put the in this case the pox one intranasally to the lungs, and it shut it off, stopped it. So it depends on the virus you're talking about. With flu, it's respiratory driven. It goes into the lungs like pox does, and so we would treat this systemically. And we've already started working with flu. We have high-path flu on site there, and for us, looking at the cell level, flu is flu, a virus is a virus, so you can call it high-path if you want, but that's a little bit different because that really affects the immune system and different things that happen.
So, in your opinion, then, this technology that you and maybe others in the private sector are working on is a new approach. It's not attacking the virus. It's helping our cells.
It's attacking.
Not be susceptible to a virus.
Exactly. It basically, we think is. I hate to use this word, but it's probably going to wind up curing some of these viruses. Looks like it's already curing herpes, this particular drug, the technology. Yeah, this is one of the things that we're discussing right now, and it's probably going to happen because of the nature of what's happening at UGA, and that is we would like to make a flu-resistant chicken, and we've already started looking at this, and it'll take some time, of course, but once we identify the gene or genes that these organisms need and the cell doesn't, see, that's the critical aspect of this, is that this technology at once gives you a target that the cell gets around somehow. It's a lot of redundancy built in cells. It's like a space shuttle. Something fails on a space shuttle, there's about 10 backups. Well, the cell is a heck of a lot more sophisticated, so it can get around things. The virus comes in with such a limited amount of information that if it is not able to find the protein it needs, it will disappear. The cell will sort of scarf it up and it goes away. So we think that what we can do at this point is if we can change the genetic or the genes of the chicken somehow by knocking out something it doesn't need, and provided it doesn't taste like fish at the other end, then we'll probably have a way to control flu. You get rid of the flu chicken, or you make a flu-resistant chicken, and the flu problem really goes away. It'll still be in wild birds, but it's not easily transmitted. It won't come into humans like it does now as easily, so we think that's probably the way to go with this ultimately. If you want to vaccinate 300 billion chickens, if you want to treat them with a drug, that's a lot of money, and it's going to take an awful lot of time.
Do you have any information just in general that you can share with the committee on
I can email you some stuff. I'll be glad to. It depends on what my patent lawyer will do. Yeah. This has been submitted for patents, and the university's involved with this too. So it's right now I'm funded from 4 different sources. There's so much excitement around this technology that it's like walking a tightrope. But I get.
Is there someone at the University of Georgia that the committee could speak with about it as well?
I'm pretty much it as far as now. You can talk to the administration about this if you need to. OVPR David Lee, who's Office of Vice President, runs the research program. But I left the CDC, packed my wife and 4 daughters, and moved to Athens. Left a pretty cush job at the CDC after 20 years, and so I'm very committed to this. And but as I said, there are 4 different ways that we're funded. One is through the private foundation, which wishes to remain anonymous. They actually asked me to help set up a genetics institute, and I told them that this was too much, this is too important to not do what I'm doing, and so they just stroked me a check for $1 million, said take it where you want to go, and then I get money from a little bit from the company and a little bit from the state, and the federal government is probably going to fund a lot of this if I decide to stay in academia. They'll fund some of it anyway.
We'd appreciate, I know I would, other members, any information you can share with us on that we can, it's always good to, if you're approaching a larger committee, public safety or appropriations, to have something in your hand you can give.
He told me not to bring anything.
I know. He's like that.
He said no slides.
But
I think so, yeah.
Even if it's just a card.
Anything written on that?
But if you don't mind, you can see Ms. Cagle there in the red dress, and she.
I don't have a card.
Love to share with you an email address. You can get stuff to her, and I can get it to the rest of the committee. So
okay.
We really appreciate the presentation.
Glad to. Okay. I'm sorry, I'm out of cards.
I do, yes.
I got a cell phone number. That might help.
And while they are gathering up their legally approved documents, we can move on. We have a couple more folks who want to address the committee, and it's a very full but very good agenda. Dr. Cool, has he left me? Here he is. In fact, I will let you just introduce yourself to the committee. A very impressive resume, and if you want to just kind of give us the short version, we're looking forward to hearing from you.
Sure. The short version is my mother says I'm a very good guy. No, the slightly longer version of that is I am an emergency physician at the Medical College of Georgia and the director of the Center of Operational Medicine there. And our emphasis is really on disaster medicine, and pandemic flu, of course, falls squarely within that. I will tell you that I am very uncomfortable using the term expert, especially when it comes to pandemic flu and following such a prestigious group as that went before me. But I did stay at a Holiday Inn Express last night, so I'll feel glad to go ahead with my presentation. I will tell you that I'm at a little bit of a disadvantage not knowing what has been covered previously, but some of the material that I'm going to cover will be redundant from what's already been covered this morning, but I will try to make sure that I speed through that material. I have to thank a lot of people. I did not reinvent the wheel in developing this presentation. There's a lot of information that you can get from the CDC, the World Health Organization, and others that you see listed up there, as well as some people at my institution, Dr. Jim Wild and Dr. Green Shepherd, that I was able to borrow some materials from. For an overview, what I'm going to do is give just a little bit of a background information from a healthcare perspective and how we see pandemic flu affecting the healthcare system, which is already in crisis. So a pandemic influenza thrown on top of that is really reason for concern. Talk about the scope of the problem and impact on Georgia specifically, and then response issues to the pandemic, and finally with some recommendations. So we've already talked about, of course, is what is flu, and of course this sudden onset of respiratory illness with fever. Of course, we go through this every year. We have regular outbreaks of flu, and of course it's been covered very well exactly what those symptoms are. It is important to note, however, that we have flu occurring throughout the world with significant illness and death every year, and that this is an ongoing problem. However, of course, pandemic flu is what we're concerned about, which is that more virulent strain that we are not accustomed to, and then, of course, causes significant morbidity and mortality in the population. Different types of flu. You have type A, type B, and type C. Type C is not really reported in humans. Type B is much milder, occurs in humans only, primarily affects children, much milder little small epidemics that occur. And then type A is the one that causes a moderate to severe illness in all age groups, in humans as well as other animals, as has been discussed very thoroughly here today. What does influenza virus look like? If you look at it under an electron microscope, this is what a picture of it actually looks like. And I want to point out on here, you'll see these little things that are sticking out from the edge of the virus. If you kind of do that diagrammatically, those become extremely important. And you've heard everybody talk about the classifications of flu using H and N. You have hemagglutinins and neuraminidase are the proteins basically that are sticking out from the component of the virus. The hemagglutinins are responsible for allowing the virus to attach to the cell, and it determines the cell and species specificity. The neuraminidase release new virus particles from the cell, which are extremely important when we go to talk about classification and how these reproduce. The ribonuclear protein is the genetic material that's represented here in this coiled fashion inside of the virus. That's the genetic material, and this was discussed just a minute ago. The way that these work, of course, is they hijack the reproductive capability of the cell. So they come into the cell and then use the cell's material as far as the ability to function. They hijack it and produce more viruses. So when we talk about H's and N's, they stand for the different hemagglutinins and neuraminases, and it's used to subtype the influenza A strains. There's 16 different of the H, 9 different of the N's. And the current human subtypes are H1N1 and H3N2 primarily. The H and N antigens are also what's used to make the body produces the antibodies against, and those are also the basis for the current vaccines. So a H1N1 vaccine, for example, does not work for an H3N2 vaccine, or virus, I should say. So what is the bird flu? And again, we've covered that fairly well, but it's H5N1. Wild birds carry all known influenza subtypes, and their high versus low pathogenicity that's been discussed at length today. This is a diagrammatic representation of basically how an influenza virus infects a cell. You have the virus that comes and enters the cell via binding to a receptor. It gets internalized into that cell, into an endosome that then breaks apart and then uses the cell's complexes normally used to reproduce their genetic material, but instead it produces more components of the virus, produces it in massive quantities, and then releases that out into the extracellular space where it goes on to another cell, and each one of those can then infect another cell until this continues to occur. Every year in the United States, on average, we have about 5 to 20% of the population that gets the flu and hospitalizes about 200,000 people a year. About 36,000 people die each year from complications from the flu, which results in about $10 billion in lost productivity and direct medical cost from those individuals becoming infected. We've talked a lot about epidemics and pandemic, and we have to ask the question, why do flu epidemics occur? And the reason that we keep getting reinfected with these viruses is a process called antigenic drift. Antigenic drift are small changes in those H and N components that the body is producing the antibodies against. You get these random genetic mutations. There are inherent flaws in how this thing reproduces. So you get these inherent mutations randomly occurring, and as those occur, then those proteins change in their configuration as they're expressed on the outside of that virus. The body has made an antibody against the protein that looks a particular way. that random mutation occurs, and now that antibody doesn't recognize that as that virus again, and therefore it isn't effective anymore. Reinfection can occur in the same season, and that's why we have to get a flu vaccine every year, is it's an estimate based on other flu activity throughout the world as to what we're likely to see as the type of flu in the United States. So if you look at a diagram of pneumonia and influenza mortality over a period of weeks, and this is years, you see the years plotted out here, you see we have this normal kind of ebb and flow to that with these occasional spikes, which are little epidemics that are occurring in the influenza outbreak. Now, I can't take credit for the occasionally shift happens, but the other part that happens to this that then causes pandemic is that we get a major shift occurring in that genetic material. And that is that, I said we have these random mutations that are occurring, and that changes change in expression of those H and N particles that are expressed on the outside of the virus. What can happen, and the one that's most concerning, is either by direct infection of humans, which is less likely, or passage in an intermediate host without a reassortment occurring, you can get infection of humans. But the most concerning is when, for example, you have something like avian flu that infects a mammal, for example, such as a pig, who then simultaneously gets infected with a human influenza virus, type A virus. And you have all of that genetic material being mixed up in the cell, you can get inclusion of parts of both of those into the virus that now gets expressed. Well, if that contains those properties which allow it to be easily transmitted from human to human, now you have a new virus that has emerged and is easily transmitted from human to human, yet may contain those components which make it fatal in the original avian flu virus. When that happens, then we have a global epidemic, and this has certainly happened in the past, and you've seen some of these pictures already today. So if we go down, okay, well, how far into this are we? What's really required for a pandemic to occur? And it is that you have to have that new virus of that strain, but with the rapid person-to-person transmission is the critical part. And it has to be a strain that the population has little or no immunity to. And viruses that are pathogenic and virulent in humans, and again, must be capable of sustained person-to-person transmission. And I included a picture of the article out of the New England Journal of Medicine from the January 27th, 2005 edition, which documents person-to-person transmission of avian influenza A, the H5N1 strain, as already having occurred. It's not that sustained person-to-person transmission, but the point being that we're very close is the take-home point. Well, what about past pandemics? The Spanish flu, which has already been discussed, approximately 20 to 40 million deaths, 675,000 of those in the United States. Other outbreaks, 1957, 1968. And the potential that those have to affect the population. One thing that I want to point out about those is, yes, we've made dramatic advances in healthcare since then, but we also have made dramatic advances in healthcare since then, in that we have a much more vulnerable population. We didn't have a lot of cancer patients surviving in 1918. We didn't have a lot of patients with HIV walking around in 1918. So we've got a different population for which this pandemic is going to be hitting because of our successes in healthcare. We'll have some improvement in the technology and the ability to care for those, but we also have a more vulnerable population that is also older. If we look at pandemic flu in perspective and look at the numbers, right here, Spanish flu. Deaths from Spanish flu in the United States, compare that to wars. Korea and Vietnam down here just pale in comparison to the number of deaths caused by the Spanish flu. Another way of looking at that is what the life expectancy in the United States was during that time period. Here you have the life expectancy going along. Spanish flu hits and a 10-year drop in life expectancy because of the young people that were killed by the Spanish flu. Factors that affect the death rates: the number of people infected, the virulence of the virus, the vulnerability of the affected populations, as I was alluding to with cancer patients, even patients such as those that have rheumatoid arthritis that are taking immunosuppressant drugs in order to control their arthritis are going to be very susceptible to infection. Effectiveness of preventive measures also apply there. Now, Dr. O'Neill showed you a slide looking at numbers in Georgia. I'm looking at the same numbers here, but with a side-by-side comparison to what the United States would look at as a whole. And you'll see that I've highlighted a couple of areas, and that is if we have a moderate pandemic flu versus a severe pandemic flu, and looking at those that require hospitalization. Approximately 25,950 up to almost 300,000. You'll see a lot of variation in these numbers because there are lots of different ways of trying to calculate this and estimate this based on total population versus infectivity rate, etc. Another number I want to point out here is those that would require ICU care, a very conservative estimate of at least 3,863 and maybe up to 44,000, greater than 44,000 requiring ICU care. Why is that important? Well, yeah, the numbers themselves are bad, but those numbers placed on our current state of our healthcare system in the state will be absolutely devastating. Right now, we have patients being transferred across the state and in some cases out of state because of a lack of ICU beds due to nursing shortages as well as physical space, ventilator capability, and the number of ventilators that are available in the hospitals. There's no fat left in the system, and fat, what used to be fat in the healthcare system, we now call surge capacity, and there's little to none of it. So trying to absorb these very ill patients on a healthcare system that's already limping is extremely problematic. So if we look at kind of a situation report on avian influenza, if you had all these boxes checked, we're in pandemic. Well, this is where we are right now. We've got widespread and spreading prevalence of migratory birds. We've got continued outbreaks among domestic poultry, excuse me, not outbreaks here, but in other places in the world. You've got mammalian infections that are occurring. The virus is evolving. You've got sporadic human cases reported, about 140 reports to date. The slide's getting a little dated on that. It's mostly in healthy and young individuals with a case fatality rate of about 50% and some person-to-person transmission. The only thing that's left that needs to happen is this sustained and rapid person-to-person transmission, and we've got the makings of the perfect storm for pandemic flu. We've already looked at the current H5N1 spread. We've been very fortunate that we have not gotten it in our area yet, but again, that the possibility is still there. We've talked a little bit about immunization and the question, of course, what about the regular flu shot? And of course, no, the current vaccines do not protect against bird flu. It protects against the expected strains that are there. And there are some investigational vaccines that are out there, but we really don't know what the strain is going to be when this thing mutates and comes out and becomes very easily transmittable person to person. There is some work that's also going on a universal vaccine, which uses a different protein on those viruses that they all have in common, that if that is effective may be very useful in the event of a pandemic. And there's a lot of work going on in that area now, but it remains to be seen exactly how effective that will be. Excuse me? Yeah, that's the name of the protein. It's called the M2 protein. And this nomenclature, although it appears, you'd think somebody sat down in a lab for a year to come up with how to name it. Half the time it's just the order that the proteins were discovered and then the subvariants that are discovered after that. So this would have been the second of a class of proteins that they called M. Correct. That's the name of that protein that gets expressed on the outside of the virus that the body can make antibodies against in order to fight the infection. So how do we deal with this? If we switch into a little bit of talking about how we respond to this, public health strategies, public health becomes critical in an event such as this. With all of the surveillance and early detection, as Dr. O'Neill very well described, become incredibly important. We need to educate both the public, healthcare providers, and our leaders as to why this is a problem and how we're going to deal with it. We need to have containment and prevention strategies on both the animal side as well as on the human side and the patient side, and very well thought out response plans for how we're going to deal with this. We heard a lot about surveillance of the wildlife and agriculture. I'm not going to go into that anymore. That was covered very much in detail. Some other surveillance activities that are going on, including things such as looking at school absenteeism, and as that gets reported to a centralized database to tip off the fact that there may be an influenza outbreak occurring. And things such as that can be incredibly effective. In Georgia, I know public health is looking at EMS runs, numbers of EMS runs, as well as things such as school absenteeism, and those are all extremely important. There are a lot of challenges to response, and this is something that I want to make sure that I spend adequate time on. As Dr. O'Neill said, this is going to affect every member of society, and if I can draw some analogies to Hurricane Katrina was a failure of response because the system became overwhelmed. It was a failure of local government, and it was a failure of federal government because of a lack of communication between local government and the federal government, and then also an adequate coordination of federal resources that could have much more effectively been used to mitigate the situation. That said, our entire disaster response system in this country is based on the idea of moving resources from one area of the country that's unaffected to the area of the country that is. So, for example, we have the disaster medical assistance teams. DMAT teams are located all over the country. They're healthcare providers that become temporary federal employees. When they get activated by the federal government, the team loads up, flies down, gets in a bus, whatever, comes to the area that's effective, stands up, and augments the local healthcare infrastructure. There won't be any DMAT teams that are going to be effective during a pandemic flu. Why? Because when we need a DMAT team, so does California, so does New York, so does the rest of the country. And those healthcare providers that we would normally pull out of those areas to use as volunteers in our local area are not going to be available. They're going to be needed in their local areas. So the problem is that that whole system of shifting around those resources will be incredibly ineffective in a pandemic flu because it will be a nationwide problem. I put down here no SNS. The SNS will still be there. The question is, how effectively can the federal government move around the components of the SNS, and at what point will those become exhausted given that this is a nationwide problem? Not to mention that just the command and control aspects of doing all of this, I think, will result in a Katrina-like failure of the system, just a sheer overload from the number of requests that will be coming into the federal government through those same channels to support the response. I also have a section here on the economic healthcare systems, and I'll just say it again just because it's so incredibly important to understand. We do not have much in the way of surge capacity. We have numbers that get published on paper for at what level a hospital can surge up to. That system, however, is based on putting patients in hallways, in non-patient care areas. It's putting them on temporary cots on the floor. So when we say we have surge, but only in a disaster perspective way of looking at it. Well, why is that an issue? Is it not that we can't care for people if they're on the floor? No, but you can just imagine that the lawyers will come out of the woodwork afterwards and say, you didn't give an adequate level of care to this person, but you did someone else, and then the lawsuits will start flying. Response plans. Pre-planning is key. We must educate everybody, and I am of the belief that all education and disaster response must be all hazards. We need to educate about pandemic flu. I understand that's the focus of this group. However, preparing for pandemic flu is also preparing for a SARS outbreak, is also preparing for a large-scale terrorist attack or a bio attack. There are a lot of similarities in between those, so I don't believe we should get too focused on our education, and that we should maintain an all-hazards focus, and that is preparing for those disasters regardless of the cause, whether that's a naturally occurring event or something intentional.
Is it your understanding the feds have a template to address this, and GMA follows that template? That same template is one agreed by local government?
Yes, sir. That is the case. That is the case, and there is a very nice template. There are a lot of tools out there for helping local communities plan, as we've already heard talked about. And again, planning for pandemic flu is excellent because it is a plan in surge capacity as a major component of that. And there is a lot of crossover to these other things. But again, I want to emphasize that we want to make sure that we stay all hazards and don't get too focused. Of course, surge capacity development is a big issue as well for that very reason, that we need a broader focus. We need to educate the public. Already we saw stockpiling of drugs by the average citizen. That's not an effective use of resources. Again, simple things such as avoiding others if you're sick, cough etiquette, and not only just cough etiquette, but the second piece of that, which is most important, which is hand washing or using waterless hand sanitizers, et cetera, can all be extremely useful. Containment, limiting travel will be extremely important, especially for us in Georgia with the number of people that transit through Atlanta as a major hub. We're kind of vulnerable to that. Isolate the ill and quarantine the exposed and trace contacts, et cetera. Canceling public gatherings. All those things have been talked about fairly extensively this morning. Prophylaxis and treatment is somewhat controversial. Certainly we have guidelines for a vaccine if it becomes available because it will be in such limited quantity. And then also the question of antivirals and whether or not they will be effective, they may be effective, and who we give those to at what point in time. Can we really prevent a pandemic? It may be possible to delay it, and I think we've already talked about that. This is one advantage that you'd have if you live in a rural area. You just stay in your little place and don't go out, then your chances of becoming infected are much lower. Again, this movement restriction and social distancing can be extremely effective. We had a little outbreak of a viral encephalitis that was occurring in Richmond County in Augusta. And we saw this huge spike in cases of viral meningitis coming into the emergency department. And then school let out for Christmas break. That stopped it dead cold. It was like somebody flipped the switch and it instantly stopped. Hopefully, measures such as closing the school or canceling these public events and social gatherings and some social distancing will be extremely effective in helping to control pandemic influenza. There are federal vaccination guidelines that are out there that basically list tiers of personnel persons which should receive vaccine in what order. Tiers 1 through 4, with healthy people being down at the bottom of the list. And I'm sorry to inform the Commission that key government society leaders are in Tier 3. But Tier 2, healthy 65-year-olds and children, emergency responders, and essential services make up Tier 2. And then you see the other ones that are listed in Tier 1. What about bird flu once you get it? Can it be treated if we have pandemic influenza? And the answer is possibly, but we really don't know a lot about it right now. We do know that there is some resistance to the older drugs that are out there, the amantadine and romantadine, which work only on influenza A, that have been kind of the mainstay of treatment up until the past several years. And then these other drugs that you're familiar with called Tamiflu and Relenza have had some efficacy, but also some resistance reported already. So it remains to be seen exactly how effective these drugs will be once we hit the pandemic stage. Who should get antivirals? That's also controversial, but certainly high-risk persons, potentially for prevention if we know they're exposed, and then also should get vaccinated and continue those medications for 2 weeks. For treatment, you can begin within 2 days of the onset of symptoms. It may shorten, emphasis on may shorten the duration and lessen the symptoms from the disease. Are stockpiles of antivirals and bird flu vaccine adequate? And the answer is no. It certainly isn't. The stockpiles that currently exist, and you heard Dr. O'Neill talk about much greater detail as far as that applies to Georgia, I would actually agree with his recommendation that that's our best option for right now, is that we stockpile those medications because it is the best answer at this point that we have available to us. Community needs, the public response, we have to keep in mind that we are likely to face citizen panic. Media management is going to be huge. The media can cause that public panic to get far worse and needs to be managed appropriately and educated ahead of time. We need to make extensive use of secondary treatment triage centers and neighborhood emergency health centers, setting up locations that people can go to other than the hospital, because the hospitals will be absolutely overwhelmed, where they can receive prophylaxis and/or vaccination once it becomes available. Keep in mind, and I can't say this enough, that these numbers that we're talking about are on top of the normal community medical problems, which we're already struggling to handle effectively on a daily basis. And a pandemic on top of that just really exponentially increases the problems. Education, healthcare needs will need to be altered. For example, we'll have nurses that have never done ICU care suddenly doing ICU care on the floor of the hospital, and I mean literally the ground, on the floor, on a makeshift cot, or in a gymnasium that's now been turned into a flu ward. That requires some education, and that requires some protection also from the lawyers after the fact when those people have a bad outcome. For example, we'll also have physicians who haven't managed a ventilator in years now responsible for managing a patient on a ventilator. And then education needs also will affect the general public and their understanding of what's occurring. Just a word of caution kind of in closing. As I said, we believe very strongly in our work in disaster medicine that we have to maintain an all-hazards approach to disaster preparedness. Before 9/11, nobody was really worried about disasters. After 9/11, the focus became terrorism, and that was what everybody was chasing. Then we had the anthrax mailings, and the big buzzword became bioterrorism. Then we had the Indian Ocean tsunami, and then everybody was all worried about tsunamis. And then we had Hurricane Katrina, and then suddenly everybody became worried about hurricanes. I think it's important as we focus on pandemic flu that we don't focus too tightly. Detonation of nuclear devices, rogue nations launching a missile and hitting the west coast of the United States with a 250 kiloton nuclear device are not out of the realm of possibility, and we should not lose focus, again, of an all-hazards look at this. However, as I said earlier, preparing for pandemic flu does help us address some of these other disasters that we face. For concrete recommendations, this first one may seem like it's a little bit out of the blue, but we're talking about a problem that has profound impact on public health. And currently, the status of public health in the state government is that of a division. I would recommend that it be elevated to the department level status of the state government and not remain a division within another organization. We need to re-examine and strengthen our public health laws. Recently, this was done a couple of years ago, I believe. There was a look at the quarantine issues. However, the piece of that that's still missing, in my opinion, is the law enforcement enactment. When we've discussed this with our law enforcement providers, they say, yes, we understand that the district health director can quarantine people, but you are going to have to find somebody else to keep them there. Law enforcement needs to be made very clear in the law exactly what role law enforcement will play in that quarantine enforcement if it becomes necessary, especially if we get to the point in the pandemic of civil unrest. We need to fund and foster all hazards education for our healthcare providers. Is incredibly important, not only for pandemic flu, but also those other things that I mentioned. Pandemic flu care funding is an extremely important issue. For example, most deaths from pandemic flu are likely to be due to secondary infections. Currently, third-party payer sources do not pay for those secondary infections. So if a person gets admitted to the hospital with flu, they end up in the ICU. They're in the ICU for several weeks, and they end up getting an infection because this ICU level care is being done on a general ward, or it's a disruption in supply, and we end up in situations where the best practices were not maintained, and they end up getting an infection that's considered a nosocomial or hospital-acquired infection. Third-party payers will deny the entire claim, and the hospitals eat the entire expense of that hospital stay and receive no payment whatsoever. That's a big issue. That's a big issue now, but certainly during a pandemic flu, that becomes a huge issue. Surge capacity efforts in mobile hospitals, which are already being funded, need to be expanded. That really is one of the only ways that we can expand our current surge capacity, as well as training volunteers and other personnel as, for example, nurse extenders, as well as changing applicable laws to allow that to occur during a public health emergency. And then lastly, I mentioned that we shouldn't expect the federal government to bail us out. This is an issue that we need to have stockpiles for, not only of those vaccines and medications, but also of routine medical supplies on a state level, so that we are not having to rely solely on the SNS and the federal government to bail us out during the event of a pandemic flu. And those are my recommendations. I'll be glad to entertain any questions that you may have.
I don't see any questions. I really appreciate the recommendations part of your presentation, and we would really like to have that.
Yes, sir. Be glad to get that to you.
They could stop by the red dress on the way out. We really,
yes,
really appreciate that.
Yes, sir.
Thank you very much. Dr. Bratton Woodson is the author of this bird flu manual that I think focuses on how to get your house and your family ready to deal with something like this, and I think it's very appropriate. A lot of the discussion we've had in the committee has sort of gone back to focusing on getting ready at the individual level and taking care of the family first. And so I'm looking forward to hearing from him on what I need to be doing at my house to get enough Campbell's soup, or the family ventilator, whatever the case may be. So certainly you're following what I do very well. So, Dr. Woodson, thanks for joining us, and we look forward to hearing from you.
Thank you, Representative Cox. Well, I want to tell you about a Batman TV program I saw when I was 8 years old on television. When I was a child, Batman was serialized as a 30-minute show. It was on in the afternoon after school. And I remember Gotham City was attacked by a vicious virus that was released by the Joker. And this virus was filling up the hospitals, just as we've been hearing today. People were dying. It was very serious. Batman obtained a sample of the virus. He took it down to the Batcave, and he made a vaccine, a vial of vaccine, and they saved Gotham City. All this happened within 30 minutes. The point I'm trying to make is that there isn't going to be a quick fix. We've heard two people talk about M2 virus vaccine, about the possibility of a universal vaccine. Most of our work is involved in medical research and pharmaceutical research. It takes years. It takes years to bring some new treatment to market. You cannot do it in 30 minutes. You cannot do it in 30 days. You cannot do it in 30 weeks or 30 months. So there is not, we're going to face this pandemic just like we are today, with what we have today. There is not a technical answer. There will not be a medical breakthrough that's going to come to our rescue. It's important that we all realize that with the resources that are right here today are those that are the ones that we're going to need to face this pandemic. The second important point is, you've heard it said over and over, it's not a matter of if, it's a matter of when, and so forth. Sure, we could have a mild pandemic, we could have a moderate pandemic, and we could have a severe pandemic. And no one can say ahead of time what will happen or when it will happen or so on and so forth. But the way it's shaping up, this is going to be a severe pandemic. This virus is adapting to humans just like the 1918 N1H1 adapted to humans. It is not adapting in the same way that the cause of Hong Kong and Asian flu adapted. It's not combining with human flu genes to make itself more compatible with human beings. It is not. The CDC tried to combine it through what's called reassortment with human flu and was unable to succeed. This virus is evolving strictly within the extra-human bird realm, the mammal realm, and to some extent within the human realm. But there's no exchange of RNA between human flu viruses and this virus in terms of whole genes. There might be portions of genes that are exchanged. The second thing that's important to realize is that this virus is already adapted to reproduce perfectly within the lung cell and within other cells in the body. The one thing that's keeping it from becoming pandemic is the ability to attach itself to the upper human respiratory tract. It's one small change away from pandemic. Now, this can happen in 3 different ways. The first way is by mutation. Dr. Paul Webster, who's the preeminent flu researcher at St. Jude Hospital in Memphis, says that the flu is 10 mutations away from developing pandemic status by achieving this receptor. This receptor is in the HA gene. It's what attaches to the human respiratory tract. 10 mutations is a lot of work. It may take a long time if it has to mutate 10 different times, but it can do it. The second way is by reassortment, where the
Is there they can say 10 mutations away. Is there also a timeline to
It's possible to do a timeline. And you could attach a timeline to something like that if you understood the mutation rate and all that. But Dr. Webster is, the problem is that it's not likely to occur. That's not what's likely to occur, the 10 mutations. That's like the old thing about if you had enough chimpanzees banging on a typewriter, you could get the Bible eventually, okay? That's probably not what will happen. What will probably happen are the 2 other methods. One would be exchange of a full gene, a full hemagglutinin gene with flu virus, human adapted flu virus, or a mammalian adapted virus, say in swine. The second might be the exchange of not a whole gene but a portion of a gene called recombination between a virus that lives in swine or other mammals, between the H5N1 strain and that strain of flu. And that can happen if either one of the second 2, if either one of those happen, then you go from a time of pre-pandemic to from pre-pandemic to pandemic right away. There won't be any delay. So, because the virus is otherwise adapted. I was very interested in the comments by the representative from the Department of Agriculture who said that we're in either 3 or 4, phase 3 or 4, WHO phase. WHO phase officially is 3. Almost everyone who studies pandemic influenza really thinks we're in phase 4, where there's lots of evidence that we're at limited human-to-human transition, but they haven't raised the alert phase, and I don't really know why, but it's not been raised. The more virus there is in the world, the greater the biological spread of the virus, and the more animals and species that the virus infects, the larger the number, the biomass of this reproducing organism is, the larger the chance that this organism will become pandemic. And that's why it's spread, and the number of species it's established in become what we call endemic in, including mankind, is very significant. I'd like to get along now, though, to my presentation, because I appreciate the committee's inviting me here. And what I've been interested in is what can we do if we have a pandemic? It's my opinion that as mentioned, the hospitals are going to be quite full. My doctor's office will be quite full. There won't be very much ability to see additional patients. I think the most important thing we can do is to try to help the citizens and the consumers know what they can do at home. Certainly, if I had to see an additional 1,000 patients over a 3-month period, I just couldn't possibly do it. So I think it's important that we focus on trying to help consumers be self-sufficient as they possibly can be at home for 2 reasons. First is, there are a number of preventable causes of death and disability from flu that consumers can implement at home without any medical training if they just knew what to do and when. Secondly, to the extent that consumers are well informed about how to take care of flu patients at home, this will help prevent them being brought to the hospital, which is already going to be overburdened, or the emergency department. So if we can effectively communicate to the citizens of the state how to take care of their loved ones with flu, then we can go a long way to help make the surge capacity that we do have go farther. Now the principles, Dr. O'Neill kept us out of the weeds. Well, I'm going to take us to the weeds. The reason I'm going to take us to the weeds is I want you to know just how simple this is. And I want each of us to think about our own experience with our children, with our parents, with our spouses, what we have done in our homes, and relate this to what I'm going to tell you. Now, the basic principles of taking care of a patient with flu are to keep him clean and warm and dry and emotionally comforted. You need to avoid dehydration if at all possible, and you can use some simple over-the-counter drugs to manage most of the symptoms of flu. Now, patients with flu are really not able to take care of themselves. They're quite ill. They have terrible vertigo. They're very tired. If they're dehydrated, they get up. They feel faint. They go back down again. Their eyeballs hurt. I mean, flu is not a cold or a sore throat. It's very, very severe. And pandemic flu is worse than that. It's terrible. That's why you have so many people dying. The actual number of people is 258 who've been sick, and half of those have died. Now, those are the patients with severe flu that show up in the hospitals in Asia and Africa. But the real number of patients who've been sick probably is a great deal more than 256. So I think we shouldn't expect we're going to have a 50% fatality rate when it comes to the actual pandemic flu. I think we're going to have much, much less than that. My personal projections are that it'll be more in the 8 to possibly 12% case fatality rate. The federal government's projecting a 2% case fatality rate. Nobody knows, as Dr. O'Neill said. Now, there are many simple drugs that can be used to help. There's no drug therapy is actually required for treatment of flu, but if you have access to these medications, they can really make a rough road go a lot easier. And I'd like to emphasize the fact that no medical training is required to provide good home care to flu patients. It's something anyone can do. It requires no formal medical training or experience. And the main ingredient is having good common sense, being consistent and caring. And with these elements and a little bit of guidance, we can teach many, many people how to take care of their family members. Now, I know all of us know the old aphorism, is it feed a cold or starve a fever? or is it the other way around? You know, we could take a vote now and get probably votes, half votes for one and half votes for the other. And the fact is, every one of us has experience taking care of patients with febrile illness. First of all, I'm sure each of us has had a serious febrile illness during our lives, or we've taken care of a sick child or a sick parent or a sick spouse. But despite this wealth of knowledge, most people need just a little bit of guidance on what exactly they need to do. And these are the things that I think that are most important for consumers to know. First of all, is it a flu? Is it the flu or a cold? What are the symptoms of flu? How are they treated? What resources should they have in the home stockpiled to manage flu? And what are the complications of flu? And when do these complications require the patient be taken to the hospital? These, I believe, if we can help consumers understand these things, we can go a long way to reducing the burden on the hospital system. Now, is it cold or a flu? Well, the first thing is that if you don't have epidemic flu in your community, then it's not likely the illness that you have is pandemic influenza, no matter what. It's very unlikely that you're going to be the first case of flu. Flu is going to be well established before it strikes the average person. The second thing is the severity of illness. Seasonal flu is really, really bad, much worse than colds or sore throats or sinusitis, that kind of thing. But pandemic flu is exponentially worse than that. And it's very important that we communicate this to the public so they understand that this is not like many patients are misinformed about influenza. They'll often come tell us, I've got the flu. When the fact is, if they're in the office seeing you, they probably don't have the flu, because one of the ways I know patients really had the flu is when they call and say, I'm really, really sick. In fact, I'm too sick to come in to see you, but this is what I have. Now, flu's going to follow, pandemic flu in Asia is following a different course than the pandemic flu will follow once it becomes adapted to the upper respiratory tract. The pandemic flu in Asia is presenting much more as a GI infection, because the H5N1 does have the receptors to bind onto the human gastrointestinal tract, but they don't have them for the upper respiratory tract. So in Asia, around 40% of patients present with a GI type infection rather than a viral respiratory tract infection. But the typical symptoms are going to be runny nose, sore throat, fever, muscle aches and pains like you've been beaten by a rubber hose, a dry cough much more so than a wet cough, and severe weakness. Other symptoms are going to be nausea and vomiting and diarrhea. And that would occur when the patient becomes infected through hand-to-mouth contact with the virus. They're going to, if they've got a sick family member and they are cleaning up of that person and they get the virus on their hands. Another way this is going to happen, and I know this contradicts what the Agriculture Department people have said, and since they're gone, I'll mention it now. There is great concern that poultry infected with H5N1 will remain, the meat will remain infectious, that the virus will be within the bird, within the organs of the bird and on the surface of the bird in extremely high numbers, so that infected poultry has to all be destroyed. You can't just cook the bird and it be safe. In fact, most people don't realize this, but infected poultry all poultry is contaminated. Even the very best poultry preparation processes in the state of Georgia, every single carcass is contaminated with salmonella, with campylobacter, and sometimes other bacteria. Yet we don't have too much in the way of disease outbreaks from this, because people are pretty much aware of this, and they take measures to prevent it. But any poultry exposed to the virus and is ill with the virus, the meat cannot be consumed safely. And this raises up raises an issue about vaccination of these birds with H5N1 veterinary vaccines, and one of the important reasons why we don't want to do that, because the birds could be sick, be contagious, but not show outward symptoms of it. Now, we treat cough with hydration and cough syrups, and diarrhea and abdominal cramps with a clear liquid diet, and nausea and vomiting with simple medications. Avoiding dehydration is critical, and people can make a very effective oral rehydration solution at home with 1 teaspoon of salt, 3 tablespoons of sugar, and 1 quart of water, which you give to the patient until they become hydrated, indicated by return of urine output. Analgesics with aspirin, ibuprofen, naproxen, and acetaminophen also reduce fever. You treat nasal congestion with antihistamines. Now, what should we recommend that consumers have on hand at home? Well, a pound of salt, 10 pounds of sugar, 6 ounces of baking soda, and a pound of tea. These are all useful for making the oral rehydration solution and also for treatment of respiratory symptoms. They need measuring cups, kitchen spoons, straws to help make solutions, to measure urine output and so forth. Composition style notebook to keep up with the patient's medical course that can then be relayed to someone with more medical training in case something goes wrong, help them understand. A tea kettle to make tea and steam. Steam therapy is a good therapy for bronchial disorders. Household bleach. 1/8 teaspoon of bleach to a gallon of water will purify that water. Get rid of the bacteria and the virus that might be in there. You also are going to use bleach to clean your home. You make a 1 to 10 bleach solution. After you clean up, say, diarrhea or vomiting from a surface with conventional means, then you spray that surface with the 1 to 10 bleach solution, let it sit for a minute or two, and then you wipe that down, and it's truly decontaminated. Petroleum jelly, important for lubricating surfaces, especially chapped lips and so forth. Cocoa butter, this is what you can make. You can make homemade suppositories for medicine administration to patients who can't take the medications orally. You need to weigh your patients on a regular basis to get an idea of their state of health and hydration, and you want to measure their temperature. Blood pressure, dehydration leads to low blood pressure. You need to monitor that at home. There are many devices now that consumers already have familiarity and good success with using at home that will be very effective in this case. A humidifier, in humidifying the air helps patients with respiratory diseases, a pill carder to reduce doses, and latex gloves to help prevent spread of infection. Now, this is my recommended list of medications, and I think all of us realize that these over-the-counter drugs are now generic and very inexpensive. I buy my drugs at the big box discount stores, and these things only cost a few dollars for 100 ibuprofen, 100 diphenhydramine, and cough syrup, 12 ounces of cough syrup, about $3 or $4. 100 acetaminophen tablets, loperamide, which is Imodium for abdominal cramps and diarrhea, meclizine for nausea and vomiting and vertigo, and then the N95 respiratory masks, which are special surgical masks that actually prevent spread of bacteria, and these are actually available in hardware stores. So you can see that this list of items are things that most people are already familiar with. Most of them are already within the home, and they're not expensive. Now, it's my advice that we tell consumers that we should stockpile these items in the home. It's the consumer's responsibility to do this. That they need to go out and buy these things and have them on hand. That don't expect the government or anyone else to provide them for them, because the consumer needs to be the one to take care of themselves. That trying to rely on anyone else, even a neighbor, will not be a successful strategy. Now, the pandemic is likely to cause shortages of all of the items that I've listed for a variety of reasons. But common supplies like those suggested are likely to become scarce pretty quick. Now, most of these items in this list that I've given you have a long shelf life and are inexpensive, and widespread stockpiling will not affect the economy or healthcare economy at any regard. But if you don't do it now, it could be, and you wait till after the pandemic begins, there might be shortages of these items. Now, what could the state and local governments do about this? Well, I believe that despite the fact that I would make it very clear to consumers that it's their responsibility to stockpile these items and it's their responsibility to pay for them, I know for a fact there'll be many, many people who will disregard this advice, and there'll be many people who will not be prepared. Well, I think it'll be important that the state and local governments have on hand some of these simple items to prepare to help the unprepared, and especially the poor. Secondly, there could be situations where there could be displaced persons or even refugees in large numbers that would need to be cared for. And even if they prepared for the disaster at home, they may not be able they may not have brought their preparations with them if they had to suddenly leave their domiciles. So this would give the state and local governments had an emergency stockpile of these simple items. They would be able to respond to these refugees and displaced persons. Now, in my opinion, that the stockpiles should be maintained locally and distributed through the county health departments, local non-governmental organizations, organized religious communities, and volunteer community groups. And I think that these are the people that will have a better idea of who's in need. You know, we won't know in Atlanta what they need in Ludowici, but the Baptist Church, the First Baptist Church in Ludowici, may have a real good idea of who's hurting. So I think that we need to keep that in mind. Now, common complications of pandemic flu will be dehydration, bronchitis, sinusitis, otitis media, that's ear infection, and community-acquired pneumonia. Dehydration is due to a reduction in the normal body water content, and it can be caused by either decreased intake or diarrhea, vomiting, or insensible losses to the skin, which occurs with fever. When your temperature goes up, the surface of the skin attempts the blood flow increases to the surface of the skin. The water passes from the blood compartment through the skin, through the pores, and evaporates from the surface of the skin. This cools the body. But a great deal of water is also lost in the process, and it's called an insensible loss because we don't see it. We can see it in the urine, we can see it in the diarrhea, but we can't see it evaporating from the skin. And quite a bit of fluid can be lost this way without anybody actually noticing it. Dehydration will be one of the most common preventable causes of death and morbidity due to influenza. And it's easy to prevent it and treat it. In fact, if a patient becomes dehydrated, they're much, much more likely to suffer a secondary complication of flu like pneumonia, urinary sepsis, or stroke and heart attack. Stroke and heart attack are markedly increased if the viscosity or thickness of the blood is increased. And of course, when you remove the water content from the blood, that's one of the fastest ways you can increase blood viscosity. Thicker blood clots faster. Patients will get clots in the veins, they'll get them in the arteries, they'll have strokes, they'll have heart attacks. So avoiding dehydration is one of the simplest, least expensive, most applicable, and easiest to do ways of preventing serious complications from influenza. Now, as I said, it must be avoided at all costs. It can be rapidly fatal in children. Children have much less body water content compared to adults, and they can lose it faster. And again, rehydration is simple. And again, here's the formula: 1 level tablespoon of salt, 3 tablespoons of sugar, and 1 quart of water. This basically is what normal saline, D5 normal saline is in the hospital, except it's given by vein. Most patients, hospitalized patients, don't require IV fluids, although we give it to them. Most hospital patients could be given oral fluids. Certainly, almost all outpatients can be treated orally. One of the reasons that we admit patients to the hospital is they can't take oral fluids because they get dehydrated. But this is a very sophisticated formula. This is exactly what the body needs. The sugar and the water and the salt all work together to increase the absorption of fluid. If you gave just plain water, it wouldn't work nearly as well. If you gave just salt water, it wouldn't work nearly as well. If you gave sugar water, it wouldn't work nearly as well. The three components together are what are the key. Now, bronchitis, sinusitis, and otitis, when due to bacterial infections, will be a significant problem after influenza. A large percentage of patients will get these, and they'll usually emerge in the patient who's begun to recover from flu. That it happens after they've recovered from the acute episode of influenza, they're in their rehabilitation stage. Now, most of these cases will respond well to outpatient therapy with oral antibiotics, and the list down at the bottom are not the best antibiotics for treatment of these conditions, but they're going to be ones that are likely to be effective. And the important denominator in this list is that they're inexpensive, generic, and orally administered antibiotics. You know, we talk about $18 or $15 million for, Tamiflu, which I want to say I absolutely 100% support. When we talk about preparing for the worst and hoping for the best, that's what we mean. We need to be prepared for the worst. We don't want to say, well, gosh, we were afraid that in 5 years we'd be criticized for not having any Tamiflu, so we didn't do it. Well, I think that the pandemic's very likely to occur well before 5 years from now. The last one was in 1968, 38 years ago, and average they occur every 29 years. We're already overdue. No responsible scientist can sit up here and tell you it's going to happen now. That's what we've been told. It's true. I will tell you what I think. I think it's going to happen soon. I think it's really likely to happen within a year or two for the reasons I've already stated. Now, it's my opinion that viral pneumonia complicating influenza will be a more serious problem than just these respiratory infections. And flu can cause viral pneumonia directly. It's less likely than bacterial post-flu pneumonia, and it's actually less likely than the combination of bacterial pneumonia complicating flu plus viral pneumonia directly. But this complication occurs early in the course of the patient's illness. It's very serious, and it lead to rapid respiratory failure and death. And its cardinal manifestations are shortness of breath, cough, fever, and chest pain. There is an option for home treatment for mild or moderate cases of viral pneumonia with fluids, rest, analgesics, antipyretics, and cough suppressants. But these are the patients who will benefit most if they had access to Tamiflu or Relenza. And as these are the only effective treatments for influenza. Let me say that I disagree with the two presenters that did not think Relenza or Tamiflu were going to be effective for flu. They're absolutely wrong. I take care of patients with flu all the time. I can tell you that the studies show that the number of days they were sick was reduced by 1. Well, I don't understand that, because what I see is a marked difference in their recovery rate. And most important, and this was reflected in the research studies that led to the approval of Tamiflu for influenza, the number of secondary complications that these patients have, and these infections that I'm talking about, are much reduced in the patients who are treated with Tamiflu compared to others. Their hospitalizations for pneumonia were reduced 50% in the elderly, for instance. So Tamiflu really does work. Now, yes, there is a problem with resistance, but one of the things that you don't hear much about, and it's clearly documented, the flu virus to become resistant to Tamiflu has to change the neuraminidase gene, which is the receptor that allows the virus to penetrate the membrane of the cell on the way in and to penetrate it on the way out. It's very important to the infectivity and the virulence of the virus. When the virus undergoes the mutation of that neuraminidase gene to allow it to be resistant to Tamiflu, it also partially cripples itself. Tamiflu-resistant H5N1 is much less severe than native H5N1. So even though there'd be a high prevalence of resistance in the community, it would still be worth using, because what you'd be doing is you'd be screening out the non-resistant, more lethal, virulent strains and allowing in the less resistant, less severe strains. So in my opinion, it's a strategy that will be applicable and useful. And so I'm very much in favor of the state acquiring the additional 900,000 doses, because I think that it's going to be very important to have them on hand within the next 5 years. Now, bacterial pneumonia complicating influenza tends to occur, again, during the recovery phase. They're got over the acute flu, they're getting a little bit better, then all of a sudden their fever comes back, they start having a productive cough, chest pain, and shortness of breath. This it can be a fatal event. The U.S. Department of Health and Human Services estimates that 10% of the 3 million Georgians who will come down with influenza will develop bacterial pneumonia complicating this infection. So we're talking about 300,000 cases in Georgia during the next pandemic. Now, this disease, for the most part, not entirely, but can be treated with oral antibiotics. And again, the treatment would be the same ones: erythromycin, sulfamethoxazole, trimethoprim, penicillin, doxycycline, and erythromycin. There are better oral antibiotics, but they're expensive and they're not generic. And we have to consider the cost when we're talking about so many people. Now, it's my recommendation the state consider stockpiling these antibiotics for distribution during the pandemic. And again, the same list will be of great value in the management of these bacterial complications of pandemic influenza. They can be purchased at reasonable cost because they're generic. They can be provided to the health departments for local distribution, and will represent an important resource during the pandemic if conventional drug supplies become exhausted or unavailable. Most people are unaware of the fact that 80% of the pharmaceuticals or the raw materials for pharmaceuticals come from outside the United States. Many of the pharmaceuticals that come here actually are produced in other countries in Asia and Europe, and are then transported in the finished condition here. Disruption of transportation or an increased local need for those pharmaceuticals or raw materials might result in a breakdown in the supply chain and an interruption in our ability to produce pharmaceuticals in the United States. Now, the conditions that signal the patient's need for physician care include severe shortness of breath, bleeding from the nose, lungs, mouth, or rectum, bleeding from under the skin or widespread bruising, no urine output, bluish discoloration of the skin, or coma. I'll also tell you that patients with these conditions, most of them are going to die, even if they were in the hospital, especially if their ICU happens to be the broom closet down the hall. We right now, one of the common complications of influenza is something called adult respiratory distress syndrome, where the patient's own immune system attacks the lung and the lung fills with fluid. In the very best hospital in Atlanta, Georgia today, the case fatality rate's about 50% with that condition. That's assuming you have all the supplies, all the equipment, all the drugs available. If you didn't have all those things, the case fatality rate would be a lot higher. These problems with flu are severe, and they are very difficult to treat. Dehydration with circulatory collapse, again, can be prevented, but once the patient's gone into shock, and they can experience heart attacks, strokes, and brain damage, which may not be recoverable. Cytokine storm, that's a complex topic, but you probably heard about it. Lung fills with fluid, body attacks itself. Pneumonia, we've talked about that. Encephalitis. Many patients during the 1918 influenza pandemic developed brain infections directly with the virus. And this was accompanied by a number of deaths, but also by years and years of increased neurologic disorders like Parkinson's disease and so forth. And this is due, we think, to the encephalitis that occurred. The H5N1 has acquired the same gene segment that carries the receptors for the brain, and it has caused a number of cases of encephalitis in the patients who've been infected so far. Disseminated intravascular coagulation, the blood clotting system is irrevocably turned on, and the platelets and clotting factors all immediately are activated. The clots form throughout the body and the blood's within the arteries and veins. Then, because all the clotting factors have been consumed, all the plates have been consumed, then the patient bleeds to death. It causes multi-organ failure. The flu virus affects not just the lungs, but the heart, the liver, the kidneys, the brain, and patients have been their entire organ systems have been destroyed. So all these disorders have a uniformly fatal prognosis if not treated aggressively, and even then we probably wouldn't be able to recover more than half of them. And if you consider the fact that you may not be able to have access to a hospital bed during the time that the hospital is full with patients, you can imagine what it'll be like. Now, I think it's critical that we prepare the consumer to cope with the pandemic, and that we do it by increasing their awareness. But we make sure they understand that it's not a matter of if, but it's a matter of when. That we give them a reasonable, realistic assessment of what could happen. Tell them, look, they can be mild, moderate, or severe. And explain to the patients, to the consumers, that there is a difference in severity, that a severe pandemic will have wide-ranging effects, health effects, potential economic impact of unintentional unemployment, school closings, and social distancing. So,
Dr. Woodson, we've got to wrap it up at 12:30, and I don't want to cut you off, but I know that some members probably have some questions for you.
All right, okay.
And I know that we sort of cheated and read ahead into the stuff that I'm really interested in is notifying, as we're kind of getting into now, making sure the public's aware of how to do some home care. You guys have questions for Dr. Wilson?
Can't wait to read the book.
Well, what I'd like to just run by you is there's the book, and then there's also this pamphlet that really talks about the home care. And I just think it's terrific. Have you worked with anybody in state, in DHR or public health, about maybe do they have something similar to this or coming up with something like this?
Well, I produced that booklet just as an example of what can be done, and I have made this booklet available it's my intention to make this book available for use by any authority or commercial, private, or public authority that wants to use it or use it as a template. It's available on the internet. They can download it and
This is available on the internet?
Yes, available for free on the internet.
What is the website?
It's www.birdflumanual.com.
Okay.
But I mean, I think that this is the kind of thing that can be produced inexpensively and distributed. I think we also should consider, videos, video education on how to do some of these things. I think following on Dr. O'Neill's comment about public health nurses, there just aren't enough public health nurses. That's what he was telling you. But those nurses can be resources in the community. The nurses are the very best people to teach volunteers, who then can go and teach consumers. This needs to be a local. This is going to be a local event. We're going to be in the communities. We're going to be sitting with what we have in our communities to deal with this issue, not from the governmental level, from the family level, from the neighborhood level. That's what we have. That's the message we need to get across. People need to be empowered to take care of themselves. Not to expect it to come from us, from anywhere, from the physicians, from the hospitals, from the governments, from the local governments. They need to understand this is not a situation they've ever confronted before. But I think that we can use booklets like this should be produced by the Department of Health in the state of Georgia and distributed broadly. That they should use the media, like it's been said today, to alert the consumers to the importance of this document, to tell them to put it in a safe place where it can be used for the future. I think we should seek community volunteers in the neighborhood to serve as home care resources that would be trained by the Department of Health and Human Resources, public health nurses, on giving hands-on instructions how to take care of this using this type of approach, and that these people then would go back to their neighborhoods and be the ones, the actual neighborhood resource. I think we should develop videos that would teach patients the signs, the flu signs and symptoms, and their treatment. I want to just compliment Representative Cox on his excellent cough etiquette. Notice that when he coughed into his elbow. This is one of the methods that is. This is one of the methods that is recommended. Right. The two methods are to cough into a handkerchief, and if you don't have that, into your elbow. Because if you cough into your hands, you've got the virus on your hands, and whatever you touch, you then transmit the virus too. So these kinds of things, proper use of the mask, sanitation, decontamination, how to basically take care of patients, it ought to be on the educational video 24/7. I think that people need to understand one of the ways to reach them is this. The proposed public health measures that are it sounded to me like there was some question about whether they're going to be implemented. They're going to be implemented. There's no question about it. We're going to close every school in the state of Georgia, and it won't be regionally. It'll be the whole state will close all at once, because you're not going to have a flu pandemic that's in just one part of the state. It's not going to be in Little-Wissy, and that's all it's going to be in. It's going to be all over. In fact, because of Hartsville Airport, we're projected to be one of the first regions of the nation to be affected by the influenza. So we're going to close those schools. We're going to close them right away. We're probably going to cancel concerts, parades, conventions. Can you imagine Atlanta closing conventions?
How about elections?
I think elections could be affected. I really do. And I think political conventions certainly will be affected. It is possible that you could not have held an election in this fall of 1918, I promise you. You could not have done it. But if people understood that this is going to happen, there will be travel restrictions within the United States, not just to the United States, imposed by the federal government, I think this will get their attention about just how severe we're talking about. So, I think that we can educate people, that we can help them to understand that there are a lot of things that they can do to help themselves and take care of their family members at home. And using these tools is one of the methods.
Well, thanks for coming today. Really
Thank you for having me.
Comments. Great being surrounded by so many smart people. Hopefully some of that stuff is rubbed on to the legislators that have to go down and deal with this thing. And it's been a good committee, and appreciate the members, your attention, your attendance, and we look forward to having this report done probably within about 30 business days to submit to the appropriate committees in the upcoming session. So thank you very much for coming, and we'll adjourn.